Very good evening to everyone. Welcome to this webinar, which is focused on Contoura Lasik. And we will be talking about, we'll be brainstorming on all the aspects of Contoura vision, the planning, and everything. And we are very lucky to be joined by an amazing faculty today. We will also have a live station where we will be showing live planning of different types of cases on Contoura. So at the outset, I would like to welcome first our two international guest faculty here today. We are lucky to have with us Mark Lobanoff, who is from the US, who's very popular. We recently had a webinar with him on Forcides, which is what he's using for doing the Contura treatments, and it's a remarkable software. We are also joined by Mr. Sisimos Lemonis from Alcon, who is the leading the Alcon clinical team from Germany, and is again a whiz at Contura planning. With me is Dr. C.M. Wavikar from Bombay. He is the brainchild. We worked together to put this together, and we will be taking you through this whole program. Other than this, we have with us several luminaries from India who are all, doing excellent laser vision correction and Contura treatments. And we have with us chairman of the president of the IRSI, Dr. G.S. Dhami, who has been a pioneer. He was one of the first ones to start using wavelight lasers way back in 2002 when I started a few months after him. And he has been a big proponent of excimer treatments in India. We are also joined by other luminaries. We have with us Dr. Jayan Sarvate, Dr. Nitin Balakrishnan from Bombay, all again pioneer LASIK surgeons using wavelight for probably 10 to 15 years. We have Dr. Nagvekar, Sandeep Nagvekar. We have Dr. Neeta Shah. We have a young Shreyas Ramamurthy from Coimbatore, and we have the guy who's the whiz on Contura treatments, Dr. Rohit Shetty, who has actually designed a software of his own from Narayan Netrale, which makes life easy for Contura users. We will be discussing all these softwares, all the different ways of doing these treatments today. So let's please take advantage. Anybody has not been able to get this link or anybody is having a problem, please do message me or Dr. Wavikar or one of the Alcon teams. And we are happy that Entod is helping us organize this webinar today. So at the outset, I hope I haven't missed introducing anyone, and I'm sorry if I have. It's unintentional, but I would like to start off by inviting Dr. Wavikar to give the introductory talk. He will be telling us about the FDA norms and the trials which were done for Contura and how it all started, and then we'll go on from there. And please send in your questions on the web link. We will be taking up all questions and we will be helping answer all these questions. Dr. Wavikar. Now, Dr. Wavikar does not need an introduction because he's been with us for the previous webinar as well. All the same, Wavikar is a dear friend. He is very passionate about several aspects of ophthalmology. He loves biometry. He loves doing laser vision correction, femtolaser cataract surgery, and premium IOLs. And he has a special passion for Contura treatments, which he has been pursuing actively ever since it got available 3-4 years back when I also started doing it. And he has a beautiful institute in Thane in Mumbai. I've had the privilege of visiting it, all made of glass and 30,000 square feet and beautifully done. In case somebody hasn't seen it, should go and see it. Dr. Wavikar, please go ahead.
Thank you, Gaurav, for the kind words. Good evening, friends. We'll straight away get into the job. So before we go to Contura proper, we need to understand the history a little bit in understanding what FDA did, what were Alcon recommendation, and what is going to be beyond that. So FDA wanted US FDA approval. Basically, they wanted to do study to understand how topo-guided works and whether it is damaging to the eyes. So they did very simple study where the refraction was perfectly matching, and patient had very low HOA, higher order aberration. And then they came to a conclusion, yes, it helps and no damage done. So it was approved for use, commercial use. Then when the reality struck, Alcon realized that there are many examples where we need to understand the nitty-gritty, and therefore Alcon recommendations were introduced one by one. And the first of them was getting consistent and reliable readings. Next, they establish rules for when axis does not match, when the magnitude of the cylinder does not match, what to do, etc. And we'll be discussing all this in detail in the form of example. And lastly, as you know, change is constant in this world, and we have got so many brains working on a single issue, and people have come up with their own solutions, softwares. We are going to discuss all those in what section we call as beyond Alcon. So we are primarily be focusing first on Alcon recommendations, and from there we will go to beyond Alcon. Now, so we start with taking consistent and reliable readings. So there are two lectures on this. Number one is a video by Dr. Mark Lobanov, who is our international speaker. It was very nice of him to accept our invitation. And immediately it will be followed by a lecture by Dr. Nitin Balakrishnan, our own doctor from Mumbai, talking about how to get best out of video. Over to you, Dr. Mark. Your video, please.
Yes, I will share my screen here.
Yes.
Can you see the screen?
Yes.
Okay. This video was really originally designed to help technicians in different centers. The technicians were asking us questions: how do we get good varios? How do we consistently capture a good image? So forgive me if there's a little humor interjected in this, but it does help illustrate some ways that we use to try to capture a good vario image. Okay, we're here today at North Suburban with some of my fantastic technicians, and we are going to go through some tips on how to capture good vario images. So we're starting with Mike. Mike, what do you do as a patient first comes in for a LASIK evaluation? How do you capture a good vario scan?
So we always start with the vario images because I want to get a quality tear film image. If we're putting them through the pentacam first, that could potentially dry out their eye a little bit, because they're holding an eye for anywhere from 5 to 7 seconds, and multiple tries would potentially dry it out. So we want to educate the patient on what we're doing, how many images we're taking, and then also the fact they want to have their eyes wide open during that exam as well. And I think that's important. I think if you're telling the patient, what are we doing with this machine? Where are you going to be looking? What will you be seeing? How important it is to keep that eye wide open, they can participate with you a little bit more. Correct.
Okay, good. And Ashley.
Another thing we look at is patient alignment. First and foremost, when a patient comes in, the most important thing to do is go from behind the vario, come right up to the patient and make sure everything's aligned, because that's half the battle. Oftentimes you'll find that their head is a little bit too far, and you can actually remove this headrest very easily to get them even closer to the device.
And that often will change the angulation a little bit of the eye too. So sometimes if you look at the eye and it's not completely straight on, by removing that, we change the angle and we're getting a better capture.
And another thing our schedulers do is ask most patients, especially females, not to wear eye makeup on these visits. It's very important to have a clean tear film and not have a lot of mascara hanging into the vario image, because that can cause a big shadow.
And a lot of women will wear sort of a powder-based makeup on their cheeks, or on their forehead, their skin. That can get in the tear film, also can make trouble with the capture. Okay, good. All right. So, Kate, questions that tips that you may have for us?
Sometimes we find that we have patients that have really prominent brows and their eyes are much deeper set back. And when that happens, we get almost a hooded effect. And sometimes that comes from the lids themselves as well. It's almost like a baseball cap going over the top, which is going to obscure that top quadrant, which is really important for that iris registration. So we'll have another
What she's essentially saying is someone like myself is a little bit like a Neanderthal. Thanks, Kate. Heavy brow, deeper set eye. And so how might you work together with the other techs to capture someone's image like myself?
We're never above or afraid to ask another technician for assistance. So there will be 2, sometimes 3 of us in here. A lot of times just tilting the head to the side, because you're getting a shadow from the actual nose and then the brow as well. And then I would be on the other side actually, but I'll just try to reach around here. And you're just going to kind of gently take it, and you're going to be lifting as much as you can. Now, even then, sometimes you find it's not going to happen, and you actually have to bring the chin more up so that the deep set of the eye is counteracted with actually putting a prop under the chin, believe it or not.
The other thing too is sometimes as you're looking in at the image that's being captured, and I'm having a technician help lift that lid, the patient will begin to tear up. And you'll get this meniscus of tears on the inferior lid, and that's blocking some of the light. And so the tech can take a second cotton tip and just absorb some of that excess tear film, and suddenly you can capture the inferior quadrant a little bit better too. So these are some tips. I think really the biggest thing is practicing. Practice, practice, practice. Maybe having just one or two technicians capture all your varios first, let them get very experienced, let them learn the techniques, work as a team, and then teach the other techs how to do it. Especially for patients like myself, as Kate said, big nose, deep set eye. Thanks. Okay, so just a couple high points to focus on. The first thing is we always capture the vario first. Before we do an autorefractor, a manifest refraction, Pentacam, you really want that tear film to be in its most pristine state. The second thing is importing upon the technicians how important this exam is. And so when a technician struggles, I've told them, pull me out of clinic. I'm going to assist you. As surgeons, we know little tricks on how to turn the eyes. We're used to it as we operate in cataract surgery and with LASIK. And the surgeon can often just modify the rotation of the head a little bit and capture better image. But it also displays a very important message to the technician. This is important to the surgeon. If it's important enough to pull Dr. Lobanoff out of clinic, I really need to take this seriously. So these are just some tips that we share with our technicians.
Excellent video, especially that cotton bud thing is very, very useful. It will be useful not only for vario images, but images when we are taking on Varion, IOL Master, Pentacam, etc. So excellent video. We'll take questions together. Dr. Nitin Balakrishnan, please start sharing your presentation.
So Dr. Nitin is going to show us getting the best out of vario as well. So
I just need a second to share.
because I think that's really important. Very nice video, Mark. And I think this one will also be very useful for all those people who do Contoura or aspire to do Contoura, because without this, nothing works.
Okay, are my slides seen?
Yes.
Yes.
Thanks. Right at the outset, I would like to thank Gaurav, Dr. Wavikar for having me here. Most important thing with the Contoura treatment, like Dr. Mark said, is the entire treatment is dependent on the topography image which we are capturing. And therefore, as the dictum goes, garbage in, garbage out. If you have bad readings, we're going to get bad results. So like we all know, the topo laser vario captures points, about 22,000 data points from the corneal surface. It detects the Meyer edges, the pupil margin. It calculates the location of the pupil area centroid and the corneal apex. And it calculates the height data for only those areas where the Meyer images are seen. And it does not have any interpolated or extrapolated data. Now, what is most important is that the room lighting has to be very apt. When we started using the vario in the past, we used to have very dim lights. And here we found that it was very difficult to register these patients because under the strong light of the EX, the pupil would go down and there was no way I could match my pupillary size to the pupil size which was taken on the topolizer. So now what we do is we keep strong lights in the room where the topography is being done and have one light facing the patient's eye so that the pupil is well constricted and therefore it's easier to match this when we do the registration. Like Dr. Mark said, the ocular surface is most important because we are using a Placido-based system. And for this, it's very important that the patient stops wearing a soft contact lens for at least a week and a RGP lens for at least 3 weeks. Again, we need to stress that before doing any test which requires staring or any eye drops are instilled, the vario should be performed, not after that. This, I think, has already been covered by Dr. Mark. The most important thing is when we take the measurements, ask the patient to blink at least thrice and then to look straight into the central donut, the yellow donut, with the eye wide open. That means with the eyebrow raised, that is brow up. So what we normally do is we tell the patient blink, 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 brows up. So 3 B's and brow up. This is what we teach our technicians with. If the test takes longer than 4 to 5 seconds, repeat the same procedure. That is BU. Eye positioning has already been discussed. The most important thing again is for the right eye, you turn the head to the slightly to the left. For the left eye, you turn the head slightly to the right. Remember, this is a turn and not a tilt. Use a forehead spacer so that you get a better exposure. It's very important that you do an eye-to-eye test. That means you move the vario from right to left after the patient is aligned to ensure that there is no cyclotorsion which is occurring due to a head tilt. And like Mark showed, you use either a bud, or what we do is we have these small sticking plaster, which are the eyelash drapes, which come with our surgical drapes. So whatever is left over, in fact, every drape comes with at least 8 or 10. So we keep them in the OPD and we use these. It can just be stuck to the upper eyelid and to the eyebrow. So this helps in keeping the eyelashes way away. A minimum of 4 topo images are required for a Contoura treatment, but we would like to capture at least 6 images so that it helps to eliminate the outliers, the patients with poor images or images with missing data. You need to select the exams with the largest continuous area of analysis, because the ablation algorithm can't differentiate between a true defect and an artifact which is caused by an eyelid or the eyelashes. And one needs to confirm the scan centration on the corneal vertex, that is the center of the Myers, and not on the pupillary center. So this is what you initially see the overview. But before coming to the overview, it's important that you go to the display over here and click on the camera image. So when you get the camera image here, you're able to see what your technician has actually captured. Now, after that, there is this button down here called rings. So when you click on the rings, you can see all these rings which are projected onto the cornea, after which you press on the Placido button, and here you get the red and the blue lines. Now, what is important here is to see the discontinuity of the red and the blue lines. Check at what level the discontinuity occurs. So you need to measure, use the measurement tool over here. So like, see, as it's seen in this particular slide, the first level of discontinuity between the red and the blue lines is about 3.9 millimeters. So double of that would be more than our optical zone of 6.5 millimeters. So then this is a good image to use for the Contoura treatment. If this was, say, a 2.5 millimeters, that means it would be within the optical zone. The area of discontinuity of the red and the blue lines should not be within the optical zone. The next button to press here is the pupil iris button, where we can check whether the pupil is well centered and the limbus is also well defined. Having done that, we come back to the overview map. So the overview map would now give us the details of the Placido camera image. It gives us the corneal topography map as well as the color bar scale. It gives us the average half meridian curvature values at 3, 5, and 7 millimeters. It gives us the real keratometric values at the 3 millimeter zone, as well as the corneal astigmatism and the white to white diameter. And it also gives us a color graph for meridian comparison. At the same time, you can see this P and this R over here. So the P shows that this is a preferred treatment. That means this is a treatment which the software has considered that it is good for export. Now, an examination with the R over here shows that this image is good for registration. So this R would come if there is a good limbus information, whether if the pupil data is well captured and the iris image quality is well demarcated. If the R is in red, that would show that this image cannot be used for registration. Again, there is another button which is very important, which is called the AAOZ. Now, it is important that this button be seen and understood properly, because this is the optical zone analysis window. And any examination where the data coverage is more than 90%, the A would be in the green. But if it is less than 90%, you would have a red area in that particular area. As can be seen in this window, in all the quadrants, you can see the and in all the optical zones at 5.5 and 6.5, you have a green zone. So these are the preferred tests. The optical zone analysis window would automatically appear during the test. So the technician should be warned that if this occurs, that means certain areas are not being well exposed. There are artifacts due to the eyelashes like over here. So these areas, the analyzed area is not sufficient enough, and that's why 68% it shows a red. However, if you see that the analyzed area in the 6.5 zone is more than 90%, you can manually change this from excluded to preferred, because what you require is in the 6.5 millimeter zone an analyzed area of 90% or larger. So this is what a perfect examination would give you, a preferred P mark. Having done this, it's important that you compare all the 6 images what you've taken. So you go to the comparison display. On the display, you go to the compare chart. Any readings with a difference of more than 0.75 diopter should be excluded. So you run through all the 6 images which you have taken and choose the best 4 images, or if all 6 are within the 6.5, within the 0.75 diopters variance, then you could choose all 6 of them. One should also go in and check the Fourier images on the display for checks for signs of irregularities. If the irregularities are very high, one should be a little cautious and then probably redo the test, or have the check whether the technician has done it properly by the steps which I had alluded to earlier. Thank you.
Thanks, Dr. Nitin. It was a lovely, very, very useful presentation, I must say, and very nicely put across in such a short time. You did a great job. And I think moving on, we will be now going on to our next topic, which will be spoken upon by Dr. Wavikar. He will be showing us a simple case of Contoura planning, and he will be, trying to put across how Contoura is used for a straightforward case, so that we can move on from there with some of her unusual situations as well. So, Dr. Wavikar, would you like to share your screen? Meanwhile, we were having some issues with the web link initially, but now we've managed to get across. I was getting messages that audio was not working, and also that people were not able to see on the web link. So please request everybody to refresh. And if you're obviously seeing this, that means it's working for you. But for those of your friends or colleagues for whom it is not, we do have option for streaming on YouTube as well. In case it doesn't work for you, please ask your Alcon representative. They will be able to send you and forward you a YouTube link.
Fine. So you can see the screen, right?
Yes.
Okay. So first of all, we need to understand what are the basic steps for Contoura. Contoura can be done by 4 simple steps. Number 1 is selection of the maps. So once the way Dr. Nitin and Dr. Mark has shown, we have got the data is exported to the workstation, planning station, and from that we need to choose the maps. Second step is C4C12 compensation. Now we'll go into detail about what this C4C12 compensation is little later. Third is manipulating on refraction, and fourth is applying nomogram. So it's actually very simple to do Contoura planning. We'll start with one by one. Now this is the workstation. Now everybody may have different versions of the software, so the placement may be slightly different, but ultimately it is same. Now first you start with is what kind of data you got, the type of data. So I think I'll move it here. Yeah. So type of data over here, it is very important to select raw data sagittal. Raw data means there is no extrapolation, and dynamic. Okay, that is the steps in the curvature. Second thing is to see, oh my God. Second thing is to see the Q value. Now, in the beginning, do Contoura only if the Q value is in negative. Otherwise, don't do it. Once you become an expert, you can always do it. Third point is see the pupil size. All the pupils are within the same range. If you find any pupil just outside your other area values, just make a note of it. Fourth is quality of the data. what Dr. Nitin said, that we need to check the quality of data. You have another chance of checking here. And it is important that all these things are in green mark. If they are red, probably you need to delete that data. We'll come to this little later. And the fifth most important point is MAD. MAD stands for median absolute deviation. This value can vary when you delete or deselect or select any of these 5 graphs. Any graph which looks out of the common, which looks a little odd, we can select it, or you can select it also by means of looking at the Q values or the pupil size. Alcon recommendation is that this has to be 0.06 or lower, but try to get it as close to 0 as possible. So once you are done, you will see that this is the map. The bigger map is the one which we are going to treat. We have selected the map. Then C4-C12 compensation. Now, it is very important to understand that Contoura is doing 2 types of treatment. Number 1 is it is treating the refractive error, and number 2, it is treating the higher order aberration. So feed the modified refraction in the next screen as 0. So once you do that, what you are left with over here, this is only the higher order aberration which is being treated. That is the ablation profile of the HOA. Now, obviously, it is going to cause some change in refractive error. How do you know that? So you click on Zernike. Zernike is over here. Once you click on Zernike, this screen will appear. Now you look at C12 and C4. Okay, C12 is over here and C4 is over here. When you have put 0 in the first screen, which I showed a little earlier, C4 will be 0. C4 stands for the spherical refractive error. And what you have to do is that C4 value and C12 value has to be same. So for that, whatever the C12 value, 2/3 of that you enter over here in the 0 column. If you do that, you will realize that C4 value changes and C4 and C12 is same. So for example, if your C12 value is 0.15, then you have to feed minus 0.1 in this 0 column, the sphere. Okay, so let's go ahead. I'll just move this again. Yeah. So add 2/3 of that C12 value in the modified sphere. Then check out that C4 is equal to C12. After a while, you will stop checking it, but you know that you are bang on target. And this, whatever you have added in the spherical component, that 0 what I showed you, that is your compensation factor. That means that much of refractive error surprise you would have got if you are not compensated for the treatment of higher order aberration. This we need to add to the total refractive error. So then comes the third point is adjusting refraction or manipulating refraction. See, there is a nice booklet by Alcon. Please go into details of this. And we are also going to have many examples about adjusting refraction. But the most important point is that we need to consider only 3 points. Number 1, axis is matching or not. But for matching of the axis, the optical zone has to be reduced to 5 from 6.5 or 6. And once you know that axis is matching, you have to make the optical zone back to 6 or 6.5 again. Otherwise, you will land up doing treatment as 5 millimeters. The second point is cylinder power matching, for which we are going to have a lecture. And third is that you add that C4-C12 compensation. So once you have done all this, you will get what is the refractive error you are going to treat. Then comes the last step is applying nomogram. Again, nomogram is very, very personalized. Initially, it is important that we go by Alcon recommendation, but over a period of time, you will understand which one to follow and which not to follow. But that will come only after you done lot of cases. So that is very simple. Selection of the maps. Then second thing is that C4-C12 compensation. Then third point is manipulating refraction and applying nomogram. So it's a small learning curve, not big, and soon you will get used to it. Initially, better to start with FDA protocol and then go to Alcon recommendation and then go to something additional. There is no need to hurry. At the same time, it is very important to understand that we cannot do 100% Contoura cases. It is not possible. If mentally we are satisfied and we feel that the jigsaw puzzle is falling in place, then only it makes sense to go for Contoura. See, every technology, every procedure has got a place in the bigger picture of ophthalmology, and we have to respect those boundaries. And okay, another point is better to plan one day before the surgery, but the readings need to be taken fresh on the day of the surgery. Why this? Once you have planned one day before the surgery, you know what kind of case you are having. Axis is not matching, or TMR is more than acceptance, etc. And next day you take the fresh reading, just confirm everything and go ahead with it. So all the best. Now we'll go to Abdul. Abdul has done a lot of hard work. And Abdul, can you share your screen now?
Can I add something before
Yes,
we continue? The MID value, if we could go back to the place where we had the MID value and the pictures.
Yeah.
In your presentation. I don't know if it's too hard, maybe we can do it later.
We can do it later because it's okay.
Also, we have no recommendation.
You can see MID value here also.
Yes, we don't have no recommendation for the value. MID is the difference between the median and the outliers. So exactly, here we go. There's no script from Alcon that recommends to have a certain MID. The MID can be in a very reproducible measurement, very low. If you have a high aberrated cone, it can be very high. First thing that I would like to add from sides of Alcon. So MID can be used as a recognition. What I teach personally whenever we do these courses, I say we human beings are calibrated to see faces, recognize people. And so we can do in pictures. So by looking now at these 5 exams, I can see that the first, the fourth, and the fifth are very reproducible. Actually, the first, the second, and the third, they have a tear film issue, especially the third one. The third one I would exclude. Also, the MID is good or anything else. So we are going actually away from looking at only at the hard facts. The first thing is don't spend too much time there. You're an ophthalmologist. You are used to look at the topographies. Detect the ones that are not looking reproducible, and look especially for the central 3-4 millimeters. If the tear film breaks up, it's going to happen in the center. So I personally would exclude number 3 for sure.
Yes,
exactly.
Thank you, Sisimas. Actually, I was also having like a feeling that it is getting a little more technical. So thanks for simplifying it. But just as a total overview, I needed to add all the points. Ultimately, what we look at is the maps, and whatever map you don't like, you just delete it. That's the key thing.
I mean, look at us. We are really taught to recognize who is Dr. Chandasva, who is Mark, who is Nitin, who is Gaurav, right? And when we see you, we will recognize because our brain is somehow calibrated really well to see differences. I say use this. Don't go too much into the details. Look later. Also check out if there's no complete outlier. This first. Second thing is, sorry, Mark. The second thing is if you have a lower astigmatism, like 0.3 diopters here at this position, be prepared that there's no astigmatism. This is basically noise, 0.3 diopters, so the axis can be all over the places. But rule of thumb, don't spend too much time. Go there, trust your ophthalmology experience and select the ones that you don't like. You will be 99.999% of the cases.
You'll be bang on target.
Yes.
Yeah, right.
Wavikar,
excellent.
I want, if you could have everybody look right now at the resulting examination profile, the larger circle on the right. Now, if you could reselect the third image, let the third image go through. And it really, if you, I'm sorry, and it's go from dynamic to 0.2 fixed. Okay. So this is, sometimes the dynamic view will throw you off a little bit. It seems to change dramatically. So sometimes it's helpful just to go in the quarter diopter steps. The images will fix a little bit. And notice how that third image jumps out at you a little bit more in how different it is. But I want people to take Sismos's advice to heart. Don't spend too much time here. Knock out the third image again.
Change to dynamic or with 0.25.
And notice how very little the resulting examination profile changed. I don't want people to panic and think, oh my gosh, if I didn't knock out this little outlier that it's going to make a bad treatment. Notice as you add
Data is all acceptable.
Also here, don't be too careful. This is a very hard limit that we have set. If it's 97%, 98% and above within the optical zone, it's green. If it's 97, it's already question mark. So this is the reason why we should look at the raw data sagittal, because we see where we are missing data. And by the way, now you see also the third is missing a complete arc from the beginning to the end. So
yes,
don't look at this question mark. Don't take it too important. Also, it's just for you the threshold from 98% to below 98%.
And also, just to add to that, I would treat a 6.5 here, because even if you have 80% of the data between 6.0 and 6.5, that's still 80% more than if you didn't have that topographic data. So I don't let those question marks really make me worried. And I usually use the largest optical zone that I can.
I actually asked my R&D department to remove the question mark, to have either this or this, because everything else is just disturbing you.
See, but for the beginners, don't you think that we should give clear-cut guidelines? And that's why I made it simple. That the software is keeping it at not 0.25 steps. Software is keeping it at dynamic. So keep it dynamic. And just look for all these green values, so that once they have a little bit of experience, they can play with all these steps. That is the reason why I showed like this. But of course, what you are saying is absolutely right.
I would go exactly, not to make them too afraid. If you go to 6.5, which is the standard, switch to raw data sagittal, and here you have an excellent case. This excellent case is because the number 3 shows all the mistakes that are usually there when you do examination.
Absolutely,
you have tear film breaking up. You have here a complete portion at from 11 o'clock. Here you see this. It's failing. So teach your new beginners. Go look at what is coming out that is completely out of the rule, And if there's something that is not taken by the software, it's lower than 90%, it's going to be excluded anyhow. It's going to be excluded anyhow. Don't be too overcautious. The important thing is repeatability, repeatability, repeatability. If these are measurements that they look alike all the time, I have no problem either taking all of them or one less, as Mark showed. Yeah, Mark did tell us if you leave this in, the effect is very little. So what I want you to tell you is also this algorithm is very strong, it's very robust. I will show you also where it cannot help you, because if you give too much rubbish, we are not going to be able to detect where the rubbish is. But important for you, for new beginner, what I say, trust your brain, trust your vision, go there, select the ones that you feel it's out. If you want, check also the excesses, and then move ahead. If there's problems, it's usually tear film breakup. And number 3 is the perfect example for a tear film breaking up that throws up the myas completely. So these are the 3 key points that I would like to add. Other words, absolutely right. This is by the book, what you explained, except that Alcon has no recommendation for 0.06 on the MID. MID can be all over the place depending to the corner that you have. Mark, any
Fine.
comments?
I would agree with you. I do find that the MAD of 0.06 for normal, standard, routine eyes is a good way. Yes, Alcon doesn't recommend that, but it's a good way if you eliminate one scan and the MAD goes from 0.11 to 0.06, then that helps me say that's the scan to eliminate. But Sysomos is absolutely correct. For more complex eyes, this MAD will rise very high. And I'm going to calculate a case later treating keratoconus, and that MAD might be 0.36. So with more aberrated eyes, you have to relax that MAD number a bit.
Excellent. Let's go ahead, Abdul. Next point, next place. So over here, you fill all your data, and now the patient's refraction is -5, -1.24 for 25 diopter cylinder, and 170 is the axis. Now go to the next place. Pachymetry, pupil diameter, everything has been fed. Now Abdul will make modified refraction as 0. Okay, well, right now what you're seeing, the ablation profile is with everything, the refractive error as well as the higher order aberration. The moment you made it 0, it is now showing only higher order aberrations. Now click on Zernike. Yes. Now here you will see C12 is very, very low, 0.0591. So now there are 2 ways of doing it. Number 1, the theoretically the factor for correction will be -0.04, which is very, very subclinical. You want, you can add it, or you can just leave it at that place. It matters more when the ablation depth is changing quite a lot between a normal case, meaning wavefront optimized Lasik and Contoura Lasik. But you can do, for the sake of understanding, Abdul, let us put -0.04. No,
I think you should, Abdul, you should show just with 0.04 and show that the C4 and C12 starts looking similar. You know, I think as a habit, if everybody does this to begin with, it'll be good for them, even if the ablation shows very little. I mean, because later on you can understand that when to ignore it and when not to ignore it.
Exactly. Click on Zernike now. That you
now you show the Zernike. Yeah.
Now you will see that C4 and 12 are matching. Okay, both are around 0.06. So that is the way to go. Now, there are many times when you will realize that the difference is very less, but it is very important to understand that this 0.04 is the C4 C12 compensation factor, which we need to add to the original refractive error.
Dr. Wavikar, you must explain that how you picked up 0.04, because you, by experience, you picked up 0.04. Other people may just use 0.04 every time.
No, see, C12 was 0.06. So we have to put here 2/3 of that, because C12 in this case was 0.06. 2/3 of that is 0.04. That's why I put 0.04 there. So suppose you have a patient with a C12 of 0.15, then you will have to put 2/3 of that, that is 0.10. And suppose you have a patient with a C12 value of 0.24, then 2/3 of that will be 0.16. So that is the way you go. Whatever is the C12 value, 2/3 of that you add here as a compensation factor.
And then you check whether they match now. And if they don't match, you can play around with this by 0.01 or 0.02 this way or that till they
Absolutely.
match. And then you go ahead. Because, you may use 2/3 and it may not match really, but you can hit and trial. You can go up or down by 0.01 or 0.02. And then, reach a
Absolutely.
place where C4 and C12 match. So that, sorry to interject like this, but I thought, it will make things easier for people to understand.
No. It is very, very important for us to understand this point. I explained it at the time of my PPT.
Right, I understand. Yes.
But it's very important. So
Thanks,
basically, we have to understand that C4 and C12 have to be same, and whatever it requires, you have to enter in modified refraction. That becomes your compensation factor that needs to be added to the clinical sphere. After that, you are going to apply algorithm, and after that, you are going to go for treatment. That's it. The planning is over. Abdul, you can stop sharing now.
Could I make one comment very quickly?
Yep, please.
Dr. Wavikar, that was very well stated. And the last thing I'll just say to people is trust the mathematics here. If you have a patient, let's say a patient who underwent LASIK in the early era, 2001, 2002, they had a high myopic ablation, you're going to have a very flat central cornea and a steep rim, almost like the lip of a volcano. And if you have a lot of topography in the mid periphery, you sometimes have to add a lot of minus sphere to counterbalance that. I had one case where I was afraid and I didn't modify the sphere. And what that does is that ring treatment of the topography in the mid periphery mimics a hyperopic spherical correction. And I ended up with a patient who was a minus 1.25 because I didn't account for that. It looks scary when you're adding all this minus in some of these unusual cases, but trust the mathematics that Dr. Wavikar just told you.
Excellent. Yeah. Moving ahead, shall we move ahead now?
Yes,
Gaurav?
I think so. Yeah, sure. But very important point by Mark there. Yeah.
Yeah, really important. Please do not hesitate to interject because we are having a scientific discussion here, and everybody's point of view is important, and we also learning. So always, Moss and Mark, you are always welcome to interject, and all the other panelists also. So we start with now.
I would like to add one thing to Mark. Mark, you are absolutely right. And this was our experience. The first treatment we did topo-guided was in China for small optical zone. We didn't compensate for that and found out. Now, I want you also to understand that the nature of this error comes because we are using Zernike language, unfortunately. So the spherical aberration contains an amount of sphere. And we learned this mathematics, we didn't learn it by books or something like this. This was an empirical value that we found out. And this works for every treatment that you do. Either you do wavefront guided and you have spherical aberration, topography guided, you do spherical aberration. Whatever treatment you will do and has Zernike as a language will need that compensation. The same thing would count also for astigmatism. Just to be clear, if you have secondary order astigmatism, you are taking a part of the normal astigmatism to compensate for, okay? But this is very difficult to do, therefore, and I don't want to run away, but I want you to understand why Mark designed this software that is called 4CDs, because he wants to overcome the problems that the Zernike language has by looking at the taluses, as you call, and maybe you can chime in why.
Zernike is a branch of mathematics, and it's a very powerful branch of mathematics. But Zernike is a descriptive mathematics. It's trying to describe the pattern that it sees, and it's a little bit incomplete. And so patterns of higher order aberrations that are slightly different in the Zernike language, Zernike calls them the same coma or trefoil or quadrifoil or secondary astigmatism. It can't describe reality. Reality is more complex. And this is why we moved away from Zernike a little bit as we designed 4CDs.
Yes, that's right. Excellent. Excellent comment by both of you. So we move on to the examples now.
I just wanted to give a little bit the background so that you understand why the C4, C12 compensation comes, where does it come from, why we do need 4CD or other softwares. There is a reason. And the reason is unfortunately the science of the mathematics that we've been using since 2000, by the way, that was selected those days away from guided.
Yeah, correct. Shall I go ahead, Gaurav?
Yeah, please do. Yeah.
So we are starting with the examples now, one by one. And as I told you that in refraction, when you go to the third step of Contoura, that is manipulating refraction, first thing we have to check is whether axis match or not. And for that, we have a lecture by Dr. Gaurav Luthra. He has got an excellent case to present with when axes do not match. So over to you, Gaurav.
Thanks, Dr. Wavikar. In fact, no lectures, but just a short case and then the live station because that's where everything happens. I'm going to request Dr. Ruchika Patnaik, who's our cornea and refractive consultant, to just she's been working hard on our Contoura treatments, and I'll request her to come in and tell us a little bit about this patient where both eyes showed some differences in the axes, and then Abdul will show us on the live station. Dr. Ruchika, can you come online, please?
Yes, am I audible?
Yeah.
Yeah, good evening, everyone. This was an 18-year-old boy who presented to us, and he was he had read up from somewhere and he was quite keen for a Contoura treatment. So as you can see, these are his maps. His refraction in the right eye was a minus 1.5 diopter sphere with a minus 0.5 diopter cylinder at 140 degrees. And in the left eye, his refraction was a minus 0.25 diopter sphere with a minus 1 diopter cylinder at 70 degrees. And his pentacam maps were quite normal. So can we have the next
Should we?
slide?
Yeah, Abdul, to you. Start a planning session, Abdul.
So sometimes the patient wants a Contoura treatment and you have to be sure that whether you really want to do it or not. And here, Abdul is going to share the maps and then we'll take the opinion of the panelists, what they would do for a patient like this. Would they go ahead or not? And what axes would they choose? So Abdul, can you, yeah, okay. So this was the patient. Now these measurements were fairly good. I mean, we had Q values which were consistent, the astigmatism which was consistent as well. And this was the MAD was good. So this was the right eye, I think, which had the smaller astigmatism. But can we go on to the next screen, please? Okay, so this was the refractive error, and then minus 1.5 with 0.5 at 140. Can we go ahead? So coming on to the treatment, then you just go to the, yeah, just make that 0, please. So this was the aberration. And then when we looked at the Zernicase, we had the C4 and C12, there was 0.08. So Abdul, you had made the calculation the other day. So we'll use the 2/3. Can we get that? Abdul, can you put it there? Can you do the compensation? We had already planned everything. Actually, we had to avoid wastage of time. We had already done all this bit, and now this was coming up to 0.076. So they're matching now, and then we added up and did the planning. So now you had done the additional planning as well on the optimized. You go ahead with the 0.5, Abdul. And can we have the two treatments? Now, this was the dilemma. If you notice here, the axes, the measured was 166 and the clinical was 140. Now, the astigmatism is really small, but the difference in the axes is significant, and the maps were all good. All the 4 or 5 maps that we did were all kind of matching up. And so we had to take this decision whether to go ahead with a treatment based on which axes to use. And here I would like to kind of ask our panelists for what they would choose, or if you would like to see anything else here. Yeah.
Abdul, can you go to 5 millimeter?
Yeah, make the optical zone as
Yeah,
5 millimeters.
we did that too. Yes, actually, it remains the same.
It does not change.
It's no secondary order astigmatism. Okay.
Could you zero out the sphere and cylinder once more?
Abdul, make modified refraction as 0.
Yeah.
Go back to 6.5, please.
Yes, please. If you could change that optical zone to 6.5. Yes. Now, if you, in your mind's eye, draw an axis at 166. So you know the anterior corneal astigmatism is at 166 degrees. And look what is happening in the periphery 90 degrees away from that. And so if you look at the clock hours between, let's say, the 1 o'clock and also at about the 2:30 position, there are 2 raised areas that are going to be ablated.
Right.
In addition, there is an area that's going to be ablated at the 9 o'clock position. And if you think of this, you can think of a vector where the optical effect of treating those aberrations is going to, if the patient's looking through this at the phoropter, those aberrations are, that's why the anterior corneal astigmatism is at 166, but the patient's asking for 140. It's because of the effects of these peripheral aspects. And so what I probably would treat here would be, if I wasn't using Portuguese, I would probably, with this low of astigmatism, go more with a TMR approach and treat it at 166 degrees, given this particular case. Also note that the raised areas, if you look at the maximum tissue ablation, the lower left-hand corner below the colored image is 7.86. And so that's not very high. And so the effects of this, the optical effects, are going to be a little bit low, which is why I'd treat more towards a TMR approach.
But it's very central, no? This high. So if you look, you have basically a flattening at 9 o'clock, a stiffening at 3 o'clock. So in total, you have about 7 microns. So it's a half a diopter.
Let's take Rohit's opinion. Rohit, what would you do? Rohit enjoys doing these plannings too. Yeah.
So, thank you, sir. What I would do is I would go and look at the Zernicke, not for the C4, C12, but for your Coma and trefoil. If your Coma and trefoil in this case, C8 and if you look at C8 is really on the higher side. That means your Coma and trefoils are really on your higher side. That means that your tilt of axis from acceptance to 166 degrees and 144 degrees, what are you getting? 140 and 166. That 16 degree tilt could be because of that Coma, which is making, like what Mark said, it is tilting your axis towards that side. But what is happening in this patient is accommodation is trying to balance that tilt, and give the lens is actually tilting it at 140 degrees to actually negate that effect of that Coma on your cornea. So that's why he has got 140 degree. But you can treat 140. The challenge is if you don't treat it, your Coma will not be treated at that axis. And again, the lens may accommodate in some other way. So you may end up in having a different axis altogether. So if you imagine if you treat at 140 and not at 166, and imagine you do a wavefront for this, the patient may still have a small amount of Coma left, and the lens is again going to accommodate at maybe at 20 degrees. So that's the reason why you get multiple confusion that, I corrected the whole cylinder, but my cylinder today is not 140, 166, but it's at 20 degrees. It's because the lens is accommodating. So in this case, there is a significant amount of Coma compared to everything. So that is what is tilting the axis. And most important thing is if you actually put, I mean, it's not practical all the time. If you put an RGP lens and then refract him, and then probably the patient acceptance may be at 166 because you're actually negating your corneal coma.
In fact, Rohit, you brought about a very important point here, because where I also, always look at the aberrometry of these patients, because, sometimes that gives you a hint of the internal aberrations and how things are changing. So I always, when I have these situations, I would look at the eye trace or whatever aberrometry was available with anybody. And that tells you a little bit about how the lens may be behaving and how it may be compensating for what's there on the cornea. And then you could go wrong with the treatments, as you said. Abdul, can we quickly also see the other eye? Because, the other eye had a variation as well. Can you go back and look at the other eye?
Dr. Luthra,
Yeah.
can I add two things? Because I have
Yeah.
Rohit's here, and I wanted to grab him for a week or month. So I would like to pay attention also. I don't know if, Rohit, you agree. If I have a half diopter astigmatism and 5-6 microns of coma, they are balancing out. If I have a 4 diopter astigmatism, this is a little, the patient is not going to get influenced. This is very important also to understand that for low astigmatism, this plays a certain role. And Rohit, this is just a theory of mine, which it started the day that I've been with you in Bangalore. Do you think that we have accommodation learning? That means after the patient has been treated with a certain profile, he needs also his time to learn, accommodate this new optics.
If your patient is young, they neuroadapt and accommodate according to the changes in your cornea. If you're operating on a 32-year-old, 33-year-old patient, his ability to neuro accommodate is going to be very slow. So your younger patient is forgiving, the older patients are not.
I would agree with you, Rohit.
So if I can just make a small point here, sir.
Yes.
I mean, with regards to just accommodating, one small point, I mean, I comes up in a future example as well. I find that the patients who have a small residual along the axis which they already had, let's say younger patients most of the time with the rule, they're able to accommodate exceedingly well. But if by chance our correction, either with TMR, modified TMR, or any of the corrections which you've done, has resulted in a flipping of the axis, these patients find it very hard to accommodate and go on to complain even 6 months, 1 year after the treatment. Is that a common observation?
I'm going to also highlight one point. I'm just going to build on what Sisimo said. I think of it almost in terms of gravity. So if you have Jupiter here, okay, and a tiny moon, let's say you have a lot of astigmatism, 4 diopters. The effect of the moon on the rotation of Jupiter is very low. But if you have 2 bodies that are similar in mass, they have a much greater effect on each other's orbits. So if you have very low astigmatism and a fair amount of coma, they really will affect each other. If you have a massive amount of astigmatism, that coma is going to be dwarfed by the effects of the astigmatism. So that's kind of just a visualization that I use when Sisimo's taught me.
Great. So I think this was the the other eye of this patient, where the axes were, off by about 11 degrees there. And however, the measured was 0.59, whereas the acceptance was -1 cylinder. And when we brought down the optical zone, however, to 5 mm, you can see that the axis changes, and there the axes are off by almost 17 degrees. So in fact, we ended up not treating this patient with Contoura. We went ahead with an FCAT, I remember, because we were, this was some time back, and we were not comfortable treating this for all the reasons that are here. So if any of you would like to comment on the second eye of this patient.
I think the optics here make a lot of sense, because you have anterior corneal astigmatism at about 60 degrees. The patient in the clinic is asking for astigmatic correction at the foreopter 10 degrees away at 70. The reason for that, you can see there's that purple, the lightest purple, the highest amount of what I call talus, the highest amount of topographic irregularities at 90 degrees. So if you just think of vectors, you think of vectors, you've got the corneal astigmatism at 60. You have this topographic irregularity that's creating coma at 90 degrees. What is that going to do? Well, the patient's going to choose something at the phoropter in between them. So here at 70 degrees, that astigmatic correction at the phoropter makes complete sense to me. And I actually would treat this patient, again, with low astigmatism here, if I was not using Forsities. Forsities, what it does is it tells you what is the refractive effect of eliminating that coma at 90 degrees. So we'll tell you exactly which axis. But if I didn't have access to Forsities, I would treat TMR, and I would treat the manifest, in this case, at about 60 degrees. Sismos, what do you think?
I'm completely with you, and I would like to draw play effect. Look at his pupil in photopic size. It's about 4.5 millimeters. So this aberration kick much stronger in, as you would suggest. And the astigmatism again is very low. What we said before, the same thing here. I would go most probably with 0.5 at 59 degrees. And if I remember well, the pentacam did not show astigmatism at all. It showed only coma. If we have the pentacams again.
Can we see the pentacam once, Dr. Wavikar? Can you share that screen?
I make a point.
Yes, sir.
When you see a patient with low power, with having so much of acceptance cylinder is higher, it's because that the patient has a lot of corneal imperfection for which that lens is trying to compensate for. So when you see a lot of imperfection, if you see here, again, there is no cylinder on the cornea, but the patient has a high acceptance cylinder. That means that he's compensating to get you a better quality of vision. You would not see, like Sisimonis said, you will never see it in a -3 diopters of astigmatism. You always see in the lower minus, because this patient has such low minus, so low cylinder, but he's accommodating more. If they accommodate more, because by accommodating, you're actually trying to give you a better quality of vision. So that's why you have a -1 cylinder, even though the cornea shows it at 0.5, because it's accommodating double of what he has on cornea just to get him a clear picture.
True. Dr. Wavikar, can you show the pentacam for a moment, please? You have that on, I think, yeah, he has the slides for the pentacam. So on the left eye, it shows a 0.4 astigmatism as well. That's what, yeah. And the axes are...
Don't trust this value on this case. Don't trust this value, because this is SIM case. The 0.4 astigmatism is calculated by computing 407 with 423. It's about 43.95 divided by 2. So, but if you see the blue and the red, they're coming so close. I don't see a astigmatism pattern. I don't see this 8 at all. And there would be also nice to see the elevation map.
I don't think we have that here. Yeah.
Yeah, but I love to see elevation map.
Can you go to the next slide, Dr. Wavikar? Maybe we had the elevation map. Can you go to the next slide?
So I had a case where it was...
Oh, yeah. No, this is Shreyas's case. Okay.
Okay, but be careful. If your topography shows you astigmatism, and it's like this, that the blue and the red lines are coming together, closing together, for me, this is not true astigmatism. Go to your elevation map. If you don't see the clear Y shape here, then it's not astigmatism. And I didn't see here. Even on the right eye, there's only a small central. Another opportunity would be to switch to Fourier and see what Fourier does show for you. Yeah. So I find, don't forget, this sagittal map and tangential map are nothing else than a pair of glasses that wants to see something. Okay. Elevation maps are natural. They are not biased by any algorithm who tries and pretends to see radii. It's true elevation. So I want always to look at the elevation map and at the astigmatism, if they coexist and they are really true. I had a case last week that was turned in for Innovice, a completely different procedure, where you could see in the topography that there was a central island elevation prematurely, but the sagittal map interpreted it as astigmatism, central astigmatism. So this was also a point that I wanted. Otherwise, I'm completely with you. Small astigmatisms, if you see a lot of a coma that is most practically in the same amount, then it's most probably the astigmatism is going to be neglected, and the coma will be selected, especially if the coma is against the rule or oblique. Then they want to compensate this. Astigmatism with the rule will be neglected completely, and the oblique coma is then kicking in. Sorry for telling so much, but I feel in this moment, really with you experts here, I wanted to show you the technical side, what the algorithms do. They just want to see something that it's not there.
Thanks, Srinivas. I think Dr. Wavikar, we should, I think we should go on to the next case. Otherwise, we're going to run behind schedule. I think the message has gone across clearly. So, you're muted, Dr. Wavikar.
Okay, fine. Let's go ahead. We go to the next case. That is scenario where the TMR is more than the acceptance.
Yeah.
And we have Dr. Jayan Sarote presenting the case and Abdul Nafi working on the planning station.
Actually, I do not have any slides. I will just go. We have a young myope, 25 years, who his major refraction cylinder is less. So I will just directly go to the planning stage. His refraction, out of which these 6 maps, we have deselected the first 2. He has -3, -0.5 at 180, 6x6 vision. Now we go to his pachymetry and everything was okay. Then we go to the planning stage. This will go to the 0 at 5 millimeters. As you can see, the measured cylinder is about 0.90 in the same axis, which is more than what is clinical. So in this case, we have go to the Wernicke. Don't have much of variation. C4, C12 is not very significantly, so I did not compensate anything for this. Okay. So now what we do is we have to compensate for the cylinder. Cylinder is a point at 6.5. The cylindrical component, which was 0.5, we have added half of the difference. That comes to around minus 1. Here we have done -1. -1 cylinder, minus. And now to compensate for the cylindrical increase, we have decreased the sphere by half of it, that is 0.25, that comes to -2.75. 2.75. 0.25 sphere was reduced. And
Dr. Sawadi, that's a really important point that has not been made before. Can you just stop and really hit that point, that when you're changing this sphere from the manifest cylinder to treating more, you have to take half that difference, change the sign, add it to the sphere to maintain spherical equivalency.
So the cylindrical part was increased by 0.5. So we have decreased the spherical component by half of the cylindrical increase. That is what we have done. That way, and now we will be treating this this is the right eye which we have treated. The second is left eye. Yeah, there is nothing specific in this. Now go to the left eye. left eye, he had -4, -0.75 refraction at 180 degrees. And now we go to his, they make it 0. While calculating your compensation, we have to treat the all the Wernicke polynomials at 5 millimeters, so that we know how to compensate and what to compensate. Again, there was no specific compensation in this C4C12. So we directly went to the cylindrical part. Again, there was a difference of 0.9 in this. So we have corrected, increased this cylinder by again 0.5. And here, as we have increased the cylinder by 0.5, we have decreased the equivalent sphere by 0.25. That is half of the cylinder which we have increased, and make it -3.75. As the axi were matching the same 180 degrees, we have taken that 180 degrees. We can take 178 also. So this was a fairly simple calculation as opposed to the brainstorming session with the axis not matching. So this is what we will be doing. That is the cylindrical component, which is there's a difference in the cylinder. We treat half of the cylinder in myopia, and we compensate half of the cylinder which has been increased in the spherical part, that we decrease by half the cylindrical component which we have treated more. So this is what is the in nutshell I would like to tell you. Thank you.
Can I make a small point over here?
Yeah. Yes, please.
Yes, Nitin, please.
The only thing is, that was an excellent presentation, Dr. Sarvati. The only thing is, with the Wernicke's, for the C4C12 compensation, I would still do it at the zone which I'm treating and not at the 5 millimeter.
It was a nice presentation. And the most important point you brought forward is that the spherical equivalent has to be kept constant. Now, I have got 2-3 queries here. People do not have clear-cut message as to what is to be done when axes do not match. So I'll summarize first and I'll ask others to comment. First point is that usually you get this problem only in low cylinders. In higher cylinder, you may not get this problem as frequently. Second thing is that you look at the graph properly, as Dr. Mark said, and see whether any elevation bump or he calls it talus is making the axis shift. Third point he made is that see whether the aberrations are in the central zone 5 millimeter or too far away. that they will not have much effect. Fourth point was made by Dr. Rohit Shetty is that age is important. Youngers, they compensate very easily, but older people, accommodation
cornea or the lens that will remain there, you actually don't, you want to treat at that 85-degree axis so that you're counterbalancing that, you're treating some of it. And like you said, so I would treat at 85 degrees and I would lower the cylinder. I think -1 is perfect. I think your analysis is spot on.
For people, viewers, they would want to know why -1 and not 1.5. That's because if you keep everything zero, see, without correcting anything, the patient is getting a 10 microns of see, what you're seeing is astigmatic correction. This is what you're seeing is donut shaped. What you're seeing, 10 microns and 5 microns is actually a donut shaped correction of astigmatism, which is not your regular astigmatism. It is your abrometric astigmatism. So if you are treating close to 10 microns already, that means if I treat the patient full as -1.5, you will end up in a overcorrection because you already corrected close to half a diopter of cylinder. Let's assume that 10 microns is half diopter, close to around little half, more than half, maybe 0.75 diopters. So you don't need to treat fully because you have to see how much. If this donut shape had only 2 microns, then I would probably have treated at -1.5 and I would not worry about it. But here I'm a little cautious because there'll be a lot of overcorrection on this. So I'm going a little cautious. That's why this -1 and -1 spherical, I would not change much. It's a small power. It's a young patient, so it could accommodate well. So, and my axis is the axis of the lenticular axis this time because it's predominantly lenticular thing. If the question is, if this patient had no coma, no higher order aberration, then I would have not done a Contoura. I would have just gone back and done a wavefront optimize because there is no need to do a Contoura. So that is how you decide whether you need to do a Contoura or not. When you do a zero rule, if an ablation pattern has got 7, 8, 9 microns of ablation, it means that the Contoura would benefit this patient. So this is a simple definition of how do you define it. And this is my way of doing this.
And just to put one more comment there, that I completely agree with that comment. That's absolutely correct. Dr. Wexler in the United States came up with what he called the 50-50 method. So he would take the difference between the manifest cylinder and the measured cylinder. He would divide it by 2, and he would pick the axis of the manifest in cases like this. And so that would be really very close, about 0.6, really close to the 0.5 that Dr. Shetty reduced it by. So if you're like, well, if you don't have Dr. Shetty's software or my software, and you're doing this on your own, and you want a quick method, Dr. Wexler's method of taking half the difference works pretty well. It gave good results. I won't say best, but good results.
So excellent presentation. So the take-home message is that look at when the TMR is less than the clinical, we need to understand whether it is because of cornea or lenticular. If it is lenticular, according to Dr. Rohit Shetty, just go ahead with wavefront optimized treatment.
No, if you first look at the zero rule. If
yes.
The zero rule shows that there's no, like the Dr. Jayant Sarvate sir's case was classic. Yeah. There was 0. So that means that you don't need to worry about it. You can just go on wavefront. But here you cannot go to wavefront optimized because you will end up in a very bad shape.
Yeah, what I meant is that whenever corneal aberrations is not causing, there are not much corneal aberrations. It is entirely lenticular, theoretical case. And so you go ahead with wavefront optimized because you don't need Contoura. But if there is an aberration, there are aberrations, like in this case, there is a 10 micron being treated already because of the treatment of the coma, then that much cylinder needs to be subtracted from the manifest cylinder, approximately. And you can, of course, use Dr. Wexler's rule. Am I right, Dr. Rohit?
Absolutely. And this is exactly what we add. This is exactly what we have loaded in our software.
a mismatch between the planned, between the manifest and the measured refraction. The routine protocol which we all have been doing is check the current glasses, check the primary refraction, do a good cycloplegic refraction like Rohit said, and a PMT to confirm the final refraction on the day of the procedure. But in cases of refraction mismatch, very often you find that it may be an error with the refraction. I would like to present two patients over here. This is the first patient with a primary refraction of 8.5 with 0.25 diopters at 110 degrees, whereas what the measured was showing degrees. Now, the first thing which we do in such cases is ask the patient, ask the optometrist to do a refraction once more, and giving the optometrist a hint that the topographic axis is 145 degrees. So try and check whether the patient is really 110 degrees or it's an error in the refraction. So this was with the zero rule again. So on the repeat refraction here, we now get an axis of 140 degrees, but with a change in the cylinder to a 0.75. So if you see the previous, the patient was accepting only a 0.25, and now with a repeat refraction, he's accepting a 0.75, much closer to the measured. So this was one case. The same patient with the second eye, initially on refraction was not accepting a cylinder, whereas the measured was showing a cylinder of 1.21 diopters. So on a repeat refraction here, the sphere, the patient accepted a lower sphere and a cylinder at 10 degrees, and that is again much closer to the measured refraction. The second patient here with again a primary refraction of 4.75 with 0.5 at 160, whereas the measured is away at almost about 30 degrees away from the clinical refraction, and with a lot of difference in the quantum of the cylinder. So again, this patient underwent a repeat refraction, and again here we find that there is a higher acceptance of the cylinder now on repeat refraction with a decrease in the sphere. Again, much closer to the measure. The third, the second eye of this patient is an interesting this thing. What happened here was that you saw that there is the acceptance is higher than the measured. Now, whenever the acceptance is higher in the measured, especially in a with the rule astigmatism, it sets us thinking, because in most of the cases where you see the acceptance to be higher than the measured, it is against the rule astigmatism. So especially this rule, it is not it's a general observation which we made over the period of time that in case of with the rule astigmatism, you should have the measured higher than the clinical. So again, here we did a repeat refraction, and this is what we got. So this was another case where, like I said, the repeat refraction really helped. So basically, in conclusion, whenever there's a mismatch either in the power, in the axis, or in this particular rule where the with the rule astigmatism, you see a higher acceptance as compared to the manifest, it's always better to have a repeat refraction. Now, in case the repeat refraction does not give us any change, I would still say that get a repeat topo also done, and then proceed with one of the methods of treatment of mismatch which we've been discussing over here. Thank you.
I think, your talk was so relevant and so important. Here I would like to just take a poll for all our surgeons. How many of us are obsessed with doing refractions themselves in such situations, and how many of us rely on the optometrists? Because I am obsessed in doing my refractions myself for some reason. And, even though I have very good trained optometrists, I am obsessed with, doing that last day. In fact, I think doing those 2 or 3 refractions yourself, even myself on different days, I can, sometimes go back and change it. And I've canceled surgeries on a day when, I felt that something was not fitting in right. And so I don't know. I mean, I sometimes notice that, of course, I think some of our colleagues have amazing optometrists who don't, need to be kind of checked upon. But this was one feeling I got to be, a good refractive surgeon. Sometimes it helps to. Anyway, anybody has comments on
this is exactly what I was going to ask you or tell you, Dr. Gaurav, that doing the refraction ourselves in the end, especially when it comes to repeat refraction, is very, very important.
It
And
is
many
very
times,
relevant.
many times I've seen the treatment plan also changing because of that. It does not happen very often because we've got good optometrists, but it does happen significant number of times. And doing the refraction yourself is, I think, a very, very valid point you have brought forward.
And Dr. Wavikar, it's not just doing it yourself that you'll be better than the optometrist. It's just that you understand your patient better. Okay.
Precisely.
You can understand what he's using, what he's accepting, what his profession is like, what his preferences are like, what his personality is like, you know, how he's going to be in the real life situation with a particular refraction. I mean, it's a lot to do with, you know, kind of if you spend those 2-3 minutes with them, because I already have a data of like 3 or 4 of their past refractions, their current glasses and everything, and their topography and the eye trace and, you know, the eye trace axes. And I have that whole thing like in front of me. And I just spent 2 minutes, you know, always want to put that lens myself. And, you know, sometimes, you know, you can change your plans just because patient reacted in a particular way or something that you pick up about the patient.
Precisely. Understanding the
One more
patient
point,
is very
Dr.
important.
Gaurav.
Yes,
Yeah,
yes.
certainly.
One more point is when we do the refraction ourselves, very often we notice how they are answering. Like in one eye, even if they read 6x, the other eye they read 6x, they are struggling in one eye, making mistakes in the R and the S, and that is how we can make out this eye is the one which is going to give some problems, and this is the eye we need to concentrate on, which we can only do if we look at the patient ourselves.
I know that spending those 2-3 minutes with the patient
Gaurav,
is amazing. Yeah.
can I comment?
Yes, please.
Please.
Gaurav, how many of us really depend on retinoscopy, then the autorefs? What is your final check? A retinoscopy or an
The
autoref?
retinoscopy is really useful for me. You know, the moment I need to kind of cross-check something which is not fitting in, retinoscopy works so beautifully.
It becomes a very nice.
Yes, Dr. Gadami, we need to understand what is right. And we have got so many methods because many times we don't know what is right. And that's why each and every method counts. And retinoscopy, just like personal refraction, so that we understand what the patient is. Same way, retinoscopy is also very valuable too. And in the cycloplegic refraction, I will go when it comes to hypermetropic treatment.
So we would do a retinoscopy and a cycloplegic refraction for all.
Same here. Same here.
Yes.
Yes.
Great inputs. I think let's go ahead. Let's catch a little bit of pace, Dr.
Yeah. So we
much to discuss.
now see we have discussed when the cylinder power and axis are not matching. Now there are two sides of the fulcrum. One is the refractive error, and one is the HOA, higher order aberrations. And Dr. Rohit Shetty told us like when the things are not matching, how to interpret between the corneal aberrations and the lenticular astigmatism. And Dr. Nitin so told us how fine-tuning the refraction helps. Now we go back to the HOA and try to understand more about what is the correlation between coma and the cylinder from Dr. Shreyas Ramamurthy. Over to you, Shreyas.
Hello, sir. Thank you so much for having me in this program. So this is a patient with a high cylinder. As you can see on the pentacam, it's about 2.5, 2.6. I don't have any other slides. Can you just go on to the planning stage, please? So normally to be a disclaimer here, I'm not a huge fan of the TMR, where we assume that everything is to do with the anterior cornea. And as we all know, the posterior corneal astigmatism, the lens has already been alluded to so many times in this discussion, can have a significant role to play. So let's just move on to the next part of the analysis. We'll go on to the main input in the power. So it's a fairly high myope, -8 with -1.5. And you can go on to the next stage. So as you can see here, there's a significant difference in the clinical and measured. So patient with a 1.5 and a 2.59 on the measured cylinder, but the axis is quite similar. And this was one patient who did very well with the TMR, and we'll just see why when you go ahead with the 0 power. I wish Alcon made it a regular setting that we start with the 0 power and not with the actual refraction. But as you can see here, 11.5 microns of maximum ablation at an axis which is around 160 degrees at its peak. If Abdul, you can point to the right side on the ablation, and you where it corresponds very nicely. You can see that 11.5 is almost a diopter of ablation, and this is along the axis of the cylinder which the patient is accepting subjectively. So he has 1.5 diopter at around 160, and along that similar 160, you have 11.5 microns of what you would call a talus, which Dr. Lobanov very eloquently refers to. Or in this case, this was basically a coma manifesting as a added cylinder in the measured topography. So this was one patient where the cylinder was significantly higher, but the higher order aberrations correlated with it, and it was possibly only the anterior cornea. I don't have the pictures here, but when I did the eye trace and other things, there was not much in terms of internal aberrations, and all of it where this difference was coming from the cornea itself. So this was a patient where the TMR worked well. So I went ahead with a 2.59 at 167. And of course, because we were increasing almost 1.1 diopters in the cylinder, reduced the sphere by about 0.55. So I did a 7.45 in the sphere and a 2.59 or a 2.6 in the cylinder. And this was a very happy patient. I'll go on later after a few more examples come in, where I'll show a couple of cases where it didn't work out as well, where the patient was not extremely happy with the outcome and why. But this was one patient where the maps correlated extremely well, and this is where TMR worked very well. Of course, now Dr. Lobanov has been kind enough to share the 4-series platform with us, and we run every case similar to this through the platform, and which definitely correlates better. But in this was one example before we started using the 4-series platform, where one patient where the TMR worked very well. And I think it is these kind of eyes, even though there's a significant difference in cylinder, where they do extremely well with TMR. But if we are not able to correlate, or if we are not able to find a logical reason why the higher order aberration would not be adding to the cylinder, I would be quite wary of going ahead with something which is as different as in this case. Thoughts, please?
Excellent, Dr. Shreyas. Very good, very well put, especially that 11 micron difference. Now we are, as usual, we are
one
behind
question,
schedule.
please.
Dr. Dhami?
Yeah, I
Can you
have
take
a
all
question. Do you ever, once you find the difference between the measured and the manifest, do you ever go back and see what the patient really accepts, whether he accepts the measured or the manifest?
Every single time, sir. Every single time. I completely agree with you, sir. And I think Dr. Nitin's presentation was also very useful. In fact, our pre-procedure refraction is done after the topography and topolizers are all done. So our senior optometrists, only very select few who do it across all our different branches. All of them look at all these variables, and with the benefit of this knowledge, go ahead and do the refraction. So yes, we do that. But in this particular case, the patient wasn't really accepting it in the clinic. It was not that just because we had a 2.59 on the measured that the patient was accepting a higher cylinder. He did not. But he did extremely well when we did treat him with this refraction, and he was bang on Hyperopia postoperatively.
Excellent.
Thank you. This is something that I would also like to add. If we have a lot of high order aberration and we go back and check the refraction, we are not removing the high order aberrations with the glasses. So we most probably won't see an effect.
Exactly.
So I would agree that in some cases, maybe the refraction was not made properly, and this topolizer can help you, or the refraction can help you to find it out if it was properly or not. But if you have a lot of high order aberration, the phoropter can't remove them, right? So the manifest most probably will remain the same.
Yes.
Could
Mark?
Could you go back to the pentacam for this eye?
Yeah, sure. Abdul, you need to stop sharing. Can you
Notice,
see it?
yes. Okay, look at the axial sagittal curvature. Notice the bow tie. Notice two things. One, this bow tie is very central, and notice that it doesn't extend to the periphery. And this is another reason why in this particular case, although that, if there's real anterior corneal astigmatism, because the shape in the mid-periphery is there, this is another reason why the patient's accepting less at the phoropter. Also notice at the 11 o'clock position, what I refer to talus, you can see outside of the bow tie, there is another area right there. So there's some hints here. One thing that I built into Forcities is we pull maps from the Vario, but we also pull maps from the Pentacam. Because the Vario is a placidodisc topographer, the Pentacam is a Scheimpflug, and the software analyzes both to make sure there's good agreement in case that astigmatic measurement on the cornea is off in one of the devices.
Excellent point. Very important.
Here it would be also very helpful to look at the Fourier. It will tell you immediately what is going on. There will be most probably this peace, the Indian peace sign showing up, not the German thing, the Indian thing.
Excellent.
Great.
So great discussion.
Should we go ahead, Wavikar?
Yeah. So see, another thing what we need to check is how much is the difference in the ablation depth in Contoura versus wavefront optimized, and if there is a significant difference, how are you going to handle it? So we have Dr. Gaurav Luthra here, expert in this.
Thanks, Wavikar. So this patient, straightforward case. Otherwise, I mean, 1.5 sphere with 2.25 cylinder at 180 in the right eye and a 0.75 with 2.25 at 180 in the left eye. Abdul, you can show us the live station where you can show us the planning for the three things. I typically plan for all three plans are available to me when I do this. I have a Contoura planning, I have a wavefront optimized, and I have an FCAT. So if you'll quickly do the three plannings for us as we did the other day in the trial run.
Dr. Gaurav Luthra, you have to tell
I'll tell you,
how can you compare all the three in the same screen?
Right. Absolutely. So that's exactly what I'm trying to see. Let's do the Contoura planning first, and let's go to 0. And you can see that the measured and the clinical are pretty much close to each other for the astigmatism and the axes both. So we'll neutralize the C4 and C12 there. And there we have 0.117 for the C12. And I think we had put 0.05, is it? To neutralize 0.06. Just check. No.
Can you put 0.075?
Almost there. Yeah, point. Wavikar knows it on his. He has it on his tips. Yeah. 7.5.
Okay, we are almost there, but
sure,
you can go ahead with 0.07.
Yeah. So let's just add to the treatment plan and 1.57, and let's treat the measured here. Now, once we've done this, we have a treatment plan here. We have this extra additional planning, thing there, which can be used. So when we started off doing Contoura, with this, we used to make different plans, and this has made life so much easier when you have that option to plan it right from the same place. You can make 2 or 3 plans, like so that you can compare them. Now, this is the optimized plan. Let's just go ahead with this. So now you can see that we have 2 plans here. And can you make the third plan as well? The FCAT?
FCAT.
Can you make the FCAT planning as well? I always like to keep all 3 plans possible. I mean, available there. And I do use FCAT quite a bit even now. So So now we have the 3 plans there. And if you look at the 3 plans are also visible to you on the right side, the 3, treatment plans on the map. So ablation profile over there. So it becomes very easy to compare them by just clicking on the 3, can you show Abdul on but let's compare the optimized and the topo guided first. The optimized is showing a central ablation of 60 microns, and the topography guided is, are we having the same optical zones for both? Can you please check? Yeah. And on the custom Q. Okay. So I think Abdul, there is some.
Yeah. Can you go to wavefront optimize? The correction is minus 1.75 here.
Right.
And in topo guided it is minus 1.5.
That's what. There was a big difference in the 2 corrections.
Yeah. In wavefront optimize. In wavefront optimize, can you make the treatment 1 point? Not in topo. In wavefront optimize, you make a treatment 1.5, not 1.75.
Also in the topo guided, the astigmatism we were going to treat the measured.
So now we have this here.
Yeah.
Yes, very good.
Because if I remember correctly, there was a difference of almost 15 microns between the 2.
Yeah. Now it is for wavefront optimize it is 56, and for custom Q. Oh.
Abdul, Abdul, were we going to treat the right eye or the left eye, which for the example I'm reading? There was a vast difference in the treatment plans. Abdul, was it the left eye by mistake? Are we looking at the wrong eye?
While you're doing this,
I'm sorry about this. I had actually sent him the data for both eyes, and I think there was a huge difference between the treatment plans for the 2 eyes. Can we quickly run through this, Abdul? Let's not apply the C12, C4 for now for a moment, and just go ahead with the rest of the plan. It wasn't going to impact it by as much for this case. Yeah. In fact, the measured and the clinical were matching pretty well. And
come, we have to go down. That's Dara Ali's speech, which time which I'm into. Huh?
so I think there is, I think probably not this example, which I think we messed up with the case, because there was a difference of almost 20 microns. Abdul, I think, was there a mix-up because we had worked out the whole thing? There was a big difference. Anyway,
how did you approach the case? Yeah.
So I'll tell you what happened. We had figured out the 2 treatments. Now FCAT was showing about 5 microns less than even the wavefront optimized, and the Contoura treatments were almost 20 microns more than the wavefront optimized. So we did the C4, C12 compensation. We looked at, and there was not a vast difference in the astigmatism as well between the measured and the thing. And then the nomogram was almost the same that we were using for both. So we had a situation where there was a difference of almost 20 microns between the 2. And again, in this patient, we had Abdul, can you please look up and see where, I think that we've missed out somewhere on the data. So anyway, we can bring that on later on. But the situation was that we had a difference of almost 20 microns. And sometimes, FCAT actually ends up showing a much smaller correction than even the optimized. So, sometimes when we are in this situation, you're so confused whether, to go with the Contoura as well or not. And, the data is not showing why there is a 20 micron difference, because when we did the zero test, the ablation difference being the maximum and the minimum showing up there for the central was about 6 to 7 microns. And in the periphery, it was ablating at the deepest point about 11 microns. Abdul, if you remember. So, and the difference was almost 20 microns in the central ablation depth, which was why we were confused. And maybe, Abdul, if you can look it up and come back later with that particular example, which we discussed the other day, that would be nice. Actually, I shared almost 5 cases with Abdul. I think we've messed up on the case which we were planning to show here.
Abdul, when Dr. Rohit Shetty and Dr. Mark Lobanoff are showing their software, that time you search for this.
Yeah, please search for that case, and we can come back to see that later, because the whole discussion will depend on that. I think we can go on, Dr. Wavikar, and come back with my case when Abdul has sorted this out. Huh?
Yeah,
Can I add something about the additional planning and custom Q? I just want to tell you what is about Wavelight, Wavefront Optimized, and custom Q. Wavefront Optimized, when we designed it, the computer technology was very slow. So what we created was a Wavefront Optimized profile based on a keratometry of 43, Q value minus 0.2, and we calculate the Wavefront optimization briefly. Custom Q was always our target. Custom Q is Wavefront Optimized, and you have two choices. Either you do constantly custom Q, and I would recommend you to do constantly custom Q with either Q value of 0 pre-op and post-op, or the true ones. Why? Imagine if you have a -7 and a -1 astigmatism, you do the -7 sphere and then the -1 astigmatism. So this astigmatism will not have the same effect as if you do a -1 with a -1 astigmatism. Why? Because -7 heated up the cornea, dried up the cornea, and then you apply the astigmatism. So nomogram and the results with astigmatism with Wavefront Optimized, especially for high myopia and certain amount of astigmatism, are tough. If you do Wavefront Optimized, you use very much the same ablation algorithm for wavefront optimization, and it's almost always exactly the same. But with the difference that the sphere and cylinder are together in one treatment. So the astigmatism is not going to get affected for the higher myopes. Now, if you do a -1 with -125, this is not going to make the difference. A -3 with a quarter of the astigmatism is not going to make the difference. But especially in India, where we have these high myopes and astigmatism, I would recommend you to forget, whoever of you has an EX500, forget about doing Wavefront Optimized. Either you do your custom Q with 0 pre-op, 0 target, which is identical like the Wavefront Optimized, but combined in one treatment, or you use the real Q value, and this is going to further optimize your ablation algorithm, especially in the periphery, and the energy that is delivered. So this is a side note that has nothing to do with custom with topography guided, but I would really want you to think of what to do if you have cornea that is very flat, very steep, if you have a high myopia and astigmatism, or high hyperopia with high hyperopic astigmatism. Please try to use custom Q software. It's the same treatment. It's the same treatment. It's the same algorithm.
Good point, Sisimos, because I completely agree that whenever we are short on cornea and we are like trying to save some corneal ablation, I think because FCAT uses a treatment plan which is combining the sphere and the cylinder, it comes out really well. So I think that's the point is well taken. But the thing which we wanted to show, I think we'll come back later with Abdul showing us the difference between the ablation depth, and then we can discuss that better. I think we can go on to the next case where Dr. Dhami wants to show us a patient with highly aberrated cornea and how he made the treatment plan.
Probably we have already raised already in this case. Abdul, can I go to the planning, please?
You don't want to explain anything on this map?
No.
Dr. Dhami?
No.
Fine. I'll Abdul, please start share screen.
It's something similar to what Shreya showed, and Shreya showed it very nicely. What I'm going to pinpoint here is we committed a mistake. We were confused whether to go for a topo guided or a wavefront optimized. Whereas the ablations seen on 00, Abdul, can I have that, please? See, we had an aberrations of more than, next, yeah, than 11.5, but the patient on re-refraction accepted the only refraction I did it myself, a good retinoscopy was what was clinical, that is manifest. And we didn't want to put in measured, though the aberrations were high. So we went with the Contoura platform and did a manifest refraction, and we found a very satisfactory results, though this done. I need the comments from the panelists. The patient improved over his spectacle correction with manifest refraction and a Contoura platform with high order operations on the cornea.
Can you comment?
Yes. So potentially, we have removed high order aberrations that have been affecting him, right? But therefore, he had already a better pathway, a clearer vision in the center. First thing. The second thing is you have a 4.5 hours watching in a -175. Yeah. So you have also a certain magnification that increases in the retina. So all this together make him a better vision. The question is it manifest better? Is TMR better? Is it foresight better? I mean, for me, still a mysterium is like, why do I have two patients that have 45 degrees difference in axis and both systems give a fairly good vision, right? This is still something I don't really can comprehend. Now, for this case, if we go back to 00, would be nice, Abdul.
Abdul, can you stop screen sharing?
Okay, so what you can see here is basically from the central area, we are at 6 microns and the periphery is about 7.4, 7.5. So in the central area of the ablation, we have only moved 2-3 microns, 4 microns. That is not significant. If we go to the full pupil size of 7, then it could be different. That's always the question. So here we have rather a stiffening that is happening outside the optical zone. For sure, it affects the central, but overall, you regularize this situation. So he's happy. The question would be, though, if we would have done the full astigmatism TMR or a different axis, what would have been the outcome? Would it have been even better? And Forsyth's study showed actually that not the 2020s are improving, or the 2025 cases, the 2016s and 2010s are improving. This maybe also Mark can chime in and give his opinion here.
So in this case, TMR, you'd be treating -2.12 at an axis of 9 degrees. And we do have an aberration, what I call talus, at the 2 o'clock position. And as Sismos pointed out, in the close central zone, you also have an elevation. It's not quite as high. It's sort of a light purple, dark red. But notice they're aligned. Notice these two, you could draw almost a straight line between those two. And when they're aligned like this, they have an additive effect to the refractive effect. So again, think you're starting at 9 degrees with the corneal astigmatism. anterior corneal astigmatism. There's probably, with 2.12 diopters of anterior corneal astigmatism, there's also a posterior corneal effect, and likely that posterior corneal effect is 90 degrees away from the anterior. But you have a topographic, or what I call talus effect, at 14 degrees. I'm sorry, at about 40 degrees. And so it's pulling from the anterior corneal at the phoropter. The patient is pulling, they're requesting cylinder because that talus effect is pulling the light, if you will, towards that 14 degrees. When you correct the topography, that effect is going to go away. And so now the patient's going to prefer something that's closer to TMR in this case. So that's just kind of my thought on this particular case.
Thank you.
Excellent. Excellent. Very good explanation. Abdul, stop sharing.
Thank you very much, Mark.
So we go to the next case now, and the case is going to be by Dr. Meeta Shah on compound or mixed astigmatism.
Thank you, Dr. Wavikar. So these were cases which, when we started off doing LASIK vision corrections around 20 years back, we would not do. Later on, we started telling them that we may have to do it in 2 sittings. Then when the FDA norms, etc. came in, they don't fit in because they are mixed astigmatism. So we were wondering how to handle them. And as you notice in this patient, he was a 20-year-old boy coming to me since more than 5 years, and every time reading 6.9, 6.6 with difficulty. On that particular day, a few months back, when I saw him, that is just when the COVID period started, my technician was not available, and I refracted him, and I said, you're 20 years old, and I told his dad, he may see better with a laser vision correction. And then think about it, we worked him up, and can we go to the planning station up to?
You don't want to show oculizer and
Yeah, so
everything?
this was, yeah, so we can show it. This was the oculizer report of this particular patient. And next slide, Dr. Wavikar. This is just the way I would plan a patient who's for Contoura. Next slide, Dr. Wavikar. 2 things which I stress on is looking at the Zernike very well and re-refracting the patient whenever something is not matching what we had examined initially when we took the patient data onto the planning station. The rest all has been discussed in a lot of depth. I think now we can go to the planning.
Abdul, share screen, please.
Is it OS? Yes. So what we deleted in this patient was number 1, I think, Abdul. And try number 4. Yes, and then I think we did a 2 or a 3, which the 2 looked a bit off. Yeah, I think we can go on. Yeah, we go on with these scans. And the refraction entered would be 0.27, 0.25 with a minus 2.75 at 160. That is what he accepted, Abdul. Can you go to minus 2.75, Abdul? Not 2.87, 2.75. Minus 2.75 at an axis of 160. Next. So here when we make it 0, 0, the aberrations are not that bad, even though there is definitely some amount of irregularity. The Zernike, please. And if we see the Zernike, there is some amount of Coma, but it's not that bad that we saw. So when I took this patient back for re-refraction, I tried with the 170 degree axis and -3, and he was not comfortable with it, not reading well, becoming worse. And then on the minus 2.75, I put a 1.12 cylinder, and he read very well. So can we put the final refraction that I did, which was plus 0.25 with the minus 2.87. And the axis I took was 168, which I had got on the TMR. .5, 120. Can we proceed? Go on. And this was the treatment done. And the first thing this boy told me when he came back on the next day with 6/5 vision, that I've never seen the world like this before. So I want input from Mr. C.C. Moss, Dr. Rohit Shetty. How could I handle this better, or what have I missed out? Because there are no standard norms for these cases that we handle. The one thing I do look at in these patients is their age, because if they're older, I would have maybe corrected more of a plus than what I did for this boy. But initially, I wanted him to have an excellent vision, and that is why I did not overcorrect the hyperopia, even though the cycloplegic refraction was more.
If I can start with the, see, when your patient is younger, your accommodation forgives you everything. And you know, you don't have to worry at all, even if you have a residual of point plus 0.75. But the challenge is when he becomes 6 to 7 years later, when he reaches that pre-presbyopic age, then he starts getting issues with his computers, and he will start having this eye strain more. So you will not have an issue now. He will accommodate very well. It's going to be a little later.
So I have done a patient at 35 years where I have removed much more. I put a plus power much higher than what I put for this boy, because I knew he would start having the problems. And for him, I would say maybe 3/4 of what he was needing, because I knew his near would otherwise get compromised.
Because when till you're 30, your accommodation takes care of everything. It forgives you everything. You know, you don't have to worry about distance. You'll have 6'4", 20/20 and above, N6, you have no problem. But when you reach that cusp zone of 30 to 40 years, not when you reach actually presbyopia, but that zone, then you start having, they will not come to you with vision problem. They come to you with difficulty, headaches. You know, I don't feel comfortable. They give you all kinds of this problem. Sometimes we treat them as dry eye.
So, Dr. Rohit, at this age of 20 with a cycloplegic plus 1.75 acceptance, what would you have treated in the plus power?
What he accepts with the strongest fogging possible.
That was plus 0.25. I did that myself.
Exactly. But just, I would explain to him that there is some amount of latent hyperopia which may come up, and I may have to do it at some point of time.
That is always told to these patients, that you may.
As a consent form, because
it is done. It is generally done. And the other thing is, that is one of the reasons I didn't do a C4 C12 or a maximum center correction, because I didn't want to reduce the hyperopia to what he was accepting. I didn't mind it going up 0.25 rather than going lower.
Have to stop screen share.
I just go a little bit more than what he's accepting, so that I am somewhere in between.
Say maybe a plus 0.5 or 0.75.
Plus 0.5, that, because that's a zone he would not be very uncomfortable, nor he's going to be very less.
Thank you.
Yeah, very well brought. Dr. Nita, thank you very much. It was very good, and even Dr. Rohit Shetty's comments were to the point. Excellent. So now we have got another innovator here, Dr. Shreyas Ramurthy. He ended up doing smile in one eye of the patient and contoura in another. Let us try to understand why he did so. Over to you, Dr. Shreyas.
Thank you, sir. Actually, I didn't do smile in one eye and contoura in the other because of any reason other than the fact that we were doing a contralateral eye study. Obviously, initial results in some of the meta-analysis had showed that at least in a larger cohort, smile versus, let's say, a wavefront optimized LASIK did not give a huge difference as far as both sphere and cylinder was concerned. But with the initial reports coming out from TMR, from Dr. John Canelopoulos and others, it was very encouraging. And we set out to do this study of smile versus contoura LASIK. And this was in the earlier days when, when the first reports of TMR came about, and we thought that we should probably do TMR. Of course, now our understanding has evolved, and we don't do TMR in all these cases. But I'm just showing one example on where the topographic outcome is fantastic, but not necessarily the final refractive outcome. So this was a patient, as you can see here, is a compound myopic astigmatism, has a 1.75 diopter cylinder in one eye and 2.75 in the other eye. And next slide, sir. Was improving to a very good crisp 6.5. This was a randomized control trial, so we didn't really have any control over which eye underwent SMILE and which eye underwent the TMR-based Contoura Lasik. And as you can see here, there was a significant difference in the cylinder, about 0.5 diopters, though the axis was similar. Now, contrast to the previous case, which I had showed, where it was an open and shut reason on why the cylinder was higher. I mean, you had a talus along one direction, and this kind of it was about 11.5 microns of ablation. It accounted for the diopter of difference in the cylinder between the refraction and measure. Whereas if you see in this particular scan, you have two small elevations. Each of them are about 6 to 7 microns, but in totally opposite axis, one along 180 and the other along 90. It doesn't really exactly give you a clear idea. And this was a time before we started using positives, and again, we had not even started doing modified TMR, and this was a full-blown TMR, and this entire 3.25 was corrected with an adjustment for sphere to maintain the spherical equivalent. And the right eye underwent SMILE. Now, this is the post-operative pentacam, and as you can see here in the right eye, this is the eye which has undergone SMILE, mind you. And as you can see here, the pentacam shows about 1.2, 1.3 diopters of cylinder, and it is a with the rule astigmatism on the pentacam. Now, contrast, next slide, sir, please. Contrast that with the other eye, it's a much more symmetric, beautiful topography, astigmatism of only just 0.1 measured by the pentacam. And as you can see here, the anterior sagittal curvature looks as good as I have got with any other patient, and what I thought was a perfect scan. And I was thinking that this patient is going to be delighted with the left eye result as compared to the right eye. But to my surprise, the patient was extremely comfortable in the right eye, 6.6, very happy. The left eye was accepting a 0.75 90. If you remember, the patient was earlier accepting a 2.5 at 180 degrees, and we corrected a 3.25, and the correction had actually flipped, and now the patient is accepting a 0.75 at 90. So a 2.75 at 175, and we corrected a 3.25, and subsequently, if you can move to the last slide, sir. So was almost a 0.75 at 90. So, you know, it was a right eye where the had a higher topographic cylinder, but the patient had a better UCBA. Subjectively, the patient was very happy. And this, the left eye, the TMR eye had absolutely no cylinder on topography, significant residual error, and more importantly, the axis was flipped. And I've always noticed that when the axis flips, these patients are subjectively less happy. They are unable to accommodate and unable to neuro-accommodate, if we would like to call it that. Because even with time, even 6 months, 9 months after the correction, the patient continued to be unhappy, despite the fact she had such a nice topographic outcome. And I had to do an enhancement procedure for her to correct this residual error. And only then this patient was happy. So it's just an example to show that if the anterior cornea does not correlate with the higher cylinder which is showing, there's something which is probably going wrong. The patient had, if you go to the subsequent slide, sir, we ran it later retrospectively on the 4-series software, and the final recommended treatment, if you can go to the next slide, sir, was along the lines of what the subjective correction would have was closer to the subjective refraction, and possibly it is it's the small effect of the talus, not too high as we saw in the earlier 0 diopter scans as well. It was just about 3 and 4 microns. So it was probably some degree of internal astigmatism which was present in the patient. and all of this finally resulted in the final treatment vector, which should have ideally been closer to the subjective refraction, and probably the patient would have had a happier outcome. Your views,
Super
please.
presentation. Yeah, super presentation. Shreyas, you brought out a very, very important point that how any other future software like 4CDs or 3Z is going to make our life more comfortable rather than going into these nitty-gritties, which sometimes we need not calculate in the correct manner. Quick comment from Dr. Mark.
Vavi,
We'll go to the next.
The only yes, sir. I mean,
Yeah,
I think it
can
would
I
be
make
great
a
to have Sissimos as well as Dr. Lobanov comment on this. The only aspect with the 4CDs, which probably, I mean, subtle issues in a couple of cases which we've had, is there is a certain significant reliance on the subjective cylinder for us to get the internal astigmatism vector. We don't have probably reliable devices which can measure the internal astigmatism. While we take the anterior corneal astigmatism from the vario, the posterior corneal astigmatism from the pentacam, we don't really input, and of course, it has a beautiful calculator to calculate the vectors of each of the taluses, which could accommodate for the higher order aberrations. But the internal astigmatism vector is still something which we don't directly measure, and it is derived as a mathematical value, subtracting it from the final subjective vector. So that is probably one area where I'm still not sure whether I can attribute this patient was compensated for by the internal astigmatism, or was there something else which we missed?
Could I make a comment?
Yep.
Yes.
So, Dr. Kanalopoulos, I followed his TMR, and my results improved. But what I found is TMR, just as in this case, will create a perfect anterior cornea. But that doesn't mean it's perfect for the total refractive error of the eye.
Absolutely.
And so I had a very similar case to this where I treated a patient with TMR. He ended up just like this, 0.1 diopters of corneal astigmatism, anterior corneal astigmatism. This particular patient manifest with a perfect cornea was a minus 2.25 astigmatic, bitterly unhappy. And so he was 52, and I said, it has to be, his posterior cornea was normal. It had to be lenticular. I did a clear lens exchange. I took out his lens. I put in a spherical IOL. The astigmatism went to 0. So it was cases like these that I proved to myself that lenticular astigmatism is real, that we must consider it, and that TMR, although it creates a perfect anterior cornea, that does not mean it's the right cornea for that eye.
Excellent.
I couldn't agree more. I couldn't agree more. And
really true.
That's precisely why
Really excellent.
When the higher order aberrations don't correlate with the final outcome, I think we need to reconsider going with the TMR.
Fine. A quick comment by, sorry, Sissimos, please go ahead.
So first of all, we have to look also at the TMR study of Dr. Kanellopoulos. I worked with John Kanellopoulos since 2000, and this specific paper was on patients that had enough high order aberrations. Okay, so he's doing a lot more work ahead. He's looking at the wavefront and compares the wavefront high order aberrations to the topography. If they don't match, he knows there is something in the lenticular. Those patients has been excluded. Your patient would have been most probably excluded by Dr. Kanellopoulos in his study. So what he showed was the patients where high order aberration was there. Lenticular astigmatism exists, and we need to find a simple way to find this out. And this is the high order aberrations, but don't look at the maximum value, but look at the value which is surrounding the pupil and from the average medium. In your case, it was 4 microns in the center and 7 in the top. I would never imagine that 0.3 microns high order aberrations would explain this. So those are the cases where you really need to go back and say, I have lenticular, I have to exclude those patients. And the question is this patient then to be always happy if there's lower higher order aberrations? He has nothing to win from wavefront topography guided. There's nothing to win from. So wavefront optimized or custom view would have been a good match for him. And Mark's software is actually helping us. Or any other software.
One last quick point is people will sometimes say, Mark, your software is very dependent on a good manifest refraction. And I say, absolutely. But so is Wavefront Optimize and Custom Q and Smile. So people say, well, they criticize Forces. They say so much of Forces is dependent on a good manifest refraction. My retort is always, as is every other refractive LASIK procedure.
In a perfect world, we would have an autorefractometer, right? Or an Hyperopia that has higher order aberrations that you could bring in the topography guided high order aberrations and check the axis. You would put the wavefront and then to see what the patient likes more. But unfortunately, which is, I think, a possibility. So I do agree, Mark, you have to have a good manifest. The only problem that I have from the technical side is if I don't correct at the manifest the high order aberrations, I will get always his feedback with high order aberrations. With astigmatism lenticular, yes, you're on the safe side, but you need 4 CDs and the talus calculations to find out if there's internal astigmatism or not. And this is I think this is the matching point of your software, that this is me as an individual, not as an Alcon employee, but looking from the scientific point of view. If you have a manifest and you have talus and this thing is not coming together, it's lenticular. And this makes it a little bit complicated for those cases. But we have to see also that 80% of the cases, 70% of the cases, they are not so much mind-blowing as we do now, because those courses, the people go out and say, you know, oh my God, this is so difficult. How can I do ever Contoura vision? No, you never understand. It's
Dr. Lobanov, a quick point.
You have to be careful of the pitfalls.
Just a very quick point to Dr. Lobanov. Even if Forsities is dependent on subjective refraction, I think where it's really making a difference is in helping our understanding on what's actually causing the effect. I mean, whether it is these higher order aberrations, whether it's posterior corneal astigmatism. The example which I showed, I had 0.5 diopters of astigmatism on the posterior cornea, and that was not in line with the anterior cornea. So, all of these things, calculating them individually and then looking at them and analyzing them, I think Forsities has really helped us in a long way.
One last point. I know I don't want to spend too much time, but later, Dr. Emma Murthy, go back to that case and take a look. You'll notice that the Vario has a different anterior corneal astigmatic magnitude than your Pentacam. And I'm going to show why in a few slides, why that's the case, how Forsities detects that, and how Forsities knows which of those two devices is correct.
Dr. Mark, are you trying to integrate an instrument like iTracy in the Forsities so that we can take care of the internal aberrations?
So what I'm doing right now is I don't have an iTrace, but I do have a Xywave, which looks at the totalized aberrations. And then I have a G4 and Pentacam that look at the corneal higher order aberrations. And we can do subtractive mathematics. If we know the totalized higher order aberrations and the cornea, we can do subtractive mathematics to figure out what must be in the lens. I don't know, you guys could probably comment because I don't have an iTrace, but if we have a device that can truly measure the internal astigmatism, that would be fantastic, because the only way I can get that value is to calculate it mathematically.
The iTrace is a beautiful instrument. We use it very regularly, but I just find the test-retest variability values to be a little too high for my comfort. I mean, you don't get the same consistent repeated values, even if you've set a specific pupil size. The values do differ from one reading to the other, so it's difficult to compute them and take them very seriously. You can have a rough idea whether the internal astigmatism is high or low, but I would hesitate to put it in an algorithm.
I would not trust also the iTrace or any other device if you don't have the full position of the lenses. If you move only the lens from the corner away, you get spherical aberration. If you have tilted, if you have anything else, and you don't know exactly, eye trace without axial length and position of the lens doesn't make sense. First, second thing is all the Zernike polynomials calculations. At the moment that you have complex cornea, the back calculated refraction is way off. So maybe I will be able to show this together, but as simpler your cornea is, as more normal, as more reliable are your Zernike derived manifest refraction, okay? Or the wavefront refraction. As more complex this thing gets, as more unreliable your back calculated wavefront refraction gets. And this is the problem also of the eye trace. Yeah.
Yeah. So let's go to the next case. Dr. Gaurav, I would like you to present.
No, I think Dr. Nagvekar has to.
Yeah. But I'm just telling you that so that you and this fellow Abdullah Reddy, after this case, hypermetropic contour. Okay.
Sure.
We'll start with Dr. Nagvekar. Is a refractive and cataract surgeon, very well knowledgeable person from Mumbai, and he's going to talk on PRK.
Can you hear me?
Yes.
Yeah, can you move over? Next slide. Okay, so this was a lady who had, she was actually desirous of a LASIK correction, and she wanted the best possible treatment for herself. She was a low myope, uncorrected vision of 615 N5 in either eye. Her refraction showed a -1.5 diopter sphere with a -0.75 diopter cylinder at 150 in the right eye, and a -125 diopter sphere with a -125 diopter cylinder at axis 170 in the left eye. The corneal thickness was reasonable, and she had a fairly large pupil, 6.1 and 5.9 in the OS. Can we have a look at the next slide, please? So her topography on the keratograph showed a little bit of asymmetric anterior corneal astigmatism with the rule. And can we have a look at the pentacam? The next slide, please. So there was nothing very significant on the anterior or posterior float on the pentacam in the right eye. And next one, please, as well as in the left eye. And can you go forward, please? However, on the Bell and Ambrosio, you could see a final D, which was a little suspicious. And can we see the next slide, please? Yeah. And the left eye seemed to be pretty okay. So can we go to the planning station, Abdul? So these are right eye readings. No, these are the left eye. Can you go to the right eye, please? So if you look at the right eye readings, the readings that were acquired, all of them were very good, basically, and all of them met the standards. So we decided that, okay, we will try and have a look at the thing. And at this stage, can we go to the next slide, next screen? So this was the refraction as entered and the pachymetry was entered. Next slide, please. And now we are coming over here. So now when we see, the first thing that I saw is that there was a difference in the axis, 115 the clinical refraction, 174 in the measured, then the TMR. And so we decided to, okay, just let's have a look at how the higher corneal or corneal abrasion. So we did it 0, 0, and you could see that there was a talus as described, and the ablation in the periphery was about 10. Didn't have much experience, and this was early days. And since the patient was so highly demanding, I did not have the guts to go in for a Contoura treatment. And actually, because of the difference in axis, and now probably I understand it better, I decided to go for a wavefront optimized in this eye. So I would just like the seniors to comment on this. So before that, can we just have a look at the Zernike for a moment? So as you can see, the C4 was 0.00, the C12 was 0.09, and the C7 and C8 were showing about 0.32 and 0.33. So there was a significant amount of coma in this patient. But since I was not very experienced, I decided to let it go and go ahead with a wavefront optimize. Can we have a look at the preparation, at the planning for the left eye? So in the left eye, we had two readings which were a little suspicious. And what we did was that we try to reduce this optical zone to 6.0. Can you make it, Abdul? The optical zone, 6.0. Okay, so again, there were some question marks on the quality. So can we get rid of the second and third, please? And now we found that they were fairly consistent with a good MAD value. So can we go to the next screen, please? We have entered the pachymetry and the refraction. And can we go to the next one, please? Okay, now make it 0, 0. And now again, we can see that the maximum ablation in the periphery was about 10.4 with 5.5 in the center. So we decided to have a look at the Zernike. And of course, here also the C7 and C8 was high, but I decided to go and see what I can do to compensate. So C4 was 0 and C12 was 0.14. So if you can go back, Abdul, and make a correction of 0.08, which is about 2/3 of that, 0.08. And then we looked at the thing, and then it was matching quite a bit, 0.128 and 0.145. Okay, for sake of argument, we'll keep it at 0.08 only. Now we looked at the cylinder. The difference between the manifest and the measured was about 1.29. So I took half of that, which was about 0.64. So the cylinder I decided to correct was about 1.89. So can you make it about 1.89? And the axis as the topographic axis, 177. And as far as the sphere was concerned, we had a clinical refraction of -125, to which we added -0.08. So that made it 1.33. But we subtracted half of the correction given for the cylinder. That means about 0.32 was reduced, so that it became -1.01. And to that, we added the nomogram. So it made it about -1.26. And we went ahead with the correction with this, and we went ahead with a PRK. The PRK was a standard procedure. I had used an epithelial scrubber for her. The Contoura went ahead very well. Patient was quite happy with the treatment. And in fact, the patient had a 6.5 vision in this eye and a 6.6 in the right eye, which had to be done by wavefront optimize. So I had a few questions for the experts out here as to how they would have managed the first eye differently. And the next question is to Alcon as to why they cannot do a compensation for the C4, C12, as give it as a button on the software straight away, you know. And any of the comments that the seniors and other experts would like to make on this case. Thank you.
So I'll just answer that last question. I can't answer for Alcon, but this Forcities does that for you. It compensates essentially the C4, C12. It looks at the values. It does that for you. So you don't have to worry about that anymore. The other thing that I'll caution everybody here is the epithelium is contributing to the total corneal topography. So one of the advances that we're building into Forcities right now is we're building in the ability to pull OCT epithelial thickness maps. We're applying the same GIS technology and creating vectors, because if you've got an area of the epithelium that is thicker and then an area that's thinner, and you remove that, there is a refractive effect to that. So for instance, if you treat a post-RK patient who had RK 20 years ago, and you look at their epithelial thickness map, their central epithelial thickness could be 70 or 80 microns. And if you don't account for that, you are going to have a hyperopic patient afterwards, because it has that effect of almost like removing stroma. So one thing that I caution people is I do plenty of topography guided PRK. You can do it, but that could be contributing a little bit. And if you have the ability to map that, it is helpful.
Mark, do you get problem in registration? After the epithelium is removed, do you get problem in registration?
No, not really. Not really.
Dr. Mark, would you be using this epithelium mapping only for the patients who are for PRK with Contoura and not for the patients who are for LASIK with Contoura?
That is correct, because you leave the epithelium intact for the LASIK patients.
Yes.
And so it will not likely contribute to it.
Excellent. Abdul, stop sharing. so that
And
we can
what
go to
about
the
the
next
first
case.
time the axis didn't match, where it was 140 and 174? Could we have done something differently?
Oh,
Yes, because you can explain that if you go back to the zeroed out sphere and cylinder for that eye, you have your explanation.
Abdul?
You'll have your explanation why they differ.
Abdul, can you go? Can you share the screen
Abdul, please share the screen.
for the right eye?
Okay, so again, your minus cylinder anterior corneal astigmatism is at 174. At the
Measured.
Measured, yes, at the 2 o'clock position, and also close to the center. If you draw a line between those two, they are aligned. And when the two taluses are aligned, they have a synergistic effect. So picture this. Here's my astigmatism from my cornea. That talus effect is going to be pulling this up towards it. And so I would anticipate this is the reason why these two differ. Or if you run this through forcities and look at the vectors will show you exactly what's going on here. So for this particular patient, if I didn't have forcities, I'm cleaning up the topography. I probably would treat half the difference between the two in magnitude, but I would choose more the TMR axis for the astigmatic treatment.
Okay.
Now, the other thing that you'll notice is if you bring the pentacam scan back up on this case, I'm sorry to have you guys switch back and forth, but bring the pentacam back up.
Wavikar.
Abdul, you need to stop sharing.
Stop sharing.
Okay, look at that astigmatism. Look at the bow tie.
Well, no, it's
This
not
is not the case.
Oh, okay. Sorry.
Yeah, the one before that.
Which right eye, left eye?
Right eye, right eye. OD.
Right eye. Okay. So again, we've got some asymmetry here to that astigmatism. And the posterior cornea here has 0.5 diopters, so it is contributing as well. So this is, if you look at the contribution from the posterior cornea, it's going to be reducing the effect of the anterior cornea. They are 90 degrees away, roughly, it's going to be reducing that to about 80% of the posterior cornea. So let's say 0.3 diopters of effect on the posterior cornea. So you would reduce the anterior astigmatism from minus 1.7 to minus 1.4.
Yes.
And what was the manifest again?
The manifest is 125.
Yeah, so now you're a lot closer. So the posterior cornea here, it has a fairly, somewhat significant effect. It's reducing that amount from the anterior cornea. So in your mind, you're saying, okay, there's less refractive effect because of what the posterior cornea is doing. You can see that where the treatment of the taluses, the topographic treatment is going to also change what the patient's seeing the phoropter. So I would treat this with Contoura, but I rely heavily on the forcities to help me with the mathematics.
Okay.
Excellent. So basically, we are coming to the same conclusion again and again, that we need to understand what is the origin of the astigmatism, whether it is a refractive error, anterior cornea, posterior cornea, or lenticular, and then take the call accordingly. Excellent. Thank you very much. We move on to the next case, Dr. Gaurav, and
Yes.
can you show that?
Okay, let's, before we go on to the slideshow, I just wanted to ask how many of us are treating hyperopia with Contoura on the panel? Is anybody doing that? Dr. Neeta is doing that?
No, I'm not doing it.
So that leaves only Dr. Neeta. What about Mark and Rohit? Are you guys doing hyperopia?
The FDA has handcuffed us. We can't.
I am doing it only because of Dr. Rohit. inspiring me to do these cases.
Because we are not doing it, and we do get occasionally patients who need hyperopia. And I pulled out one data just for the sake of discussion. Abdul, I think Rohan has the patient details. Rohan, can you quickly show us the patient details, and then we can request either Dr. Neeta or Rohit to tell us if Rohan, can you show the patient details first? Yeah. Dr. Rohan is my colleague. He's trained by Dr. Rohit at Narayan Italy. He's just come back home and he was visiting, so I requested him to pull out this data for a hypoxic patient. Rohan, can you share your screen, please? I don't know if I can't see him. So, okay, Abdul, you can show that screen, and then we'll request one of them to help us show this planning for a hyperopia, if at all can be done. So this patient was a young gentleman, about +5 with +2 cylinder in both eyes, +4.5 or +5 sphere with +2 cylinder in both eyes, and at 90 degrees. And if Dr. Neeta would like to volunteer, or Dr. Rohit would like to volunteer on helping us plan this.
What's the cycloplegic refraction?
This is the cycloplegic refraction. In fact, he was using a correction of just about 2.5 spherical with +2 cylinder, and then we did a kind of a dry refraction first, and that was adding up to about +3.25, and then we did a full cycloplegic, and finally we were able to bring him to this refraction, and he accepted it, and then he was using these glasses for a couple of month or two, and finally then this was the cycloplegic refraction, which he did accept finally.
How old is the patient?
This young man is 1999. Yeah. So that he's about 21 years old. So it took us a couple of months to actually bring him up to this final refraction. And this was not fully the cycloplegic. There was still about 0.5 or 0.75 left, which was not corrected, which we had to kind of leave aside.
Was he happy with this?
This is what he finally accepted, and this is what we thought we might treat. We were not planning to treat the cycloplegic refraction.
So was he happier with the +4 or anything when you refracted?
No. So, he was initially, we had to take him in two steps. One, what he was already using. Then we, brought him up to about a +4.5. And then finally, after 2 months, he was brought on to this. And then, once he was accepting this nicely and happy with it, this is where he stopped, because we couldn't take him any further.
So generally what I do is that the maximum that they accept and whatever they have taken in the cycloplegic, I would take a difference of both of them and add half to whatever he accepted fully and then proceed with the correction. Mm-hmm. What is Dr. Rohit's opinion about this? Dr. Rohit?
This looks like a well worked up case. Only thing is the axis is different because the convention of the plus and the minus cylinders are different here. Yeah. But because it's a +5, even if your cycloplegic is 5.5, I would go for 5.5 and go for the complete one, because accepted 5.5 would not make a difference. And do the full cylinder with the 6 o'clock zone is very important. And hyperopia works very well because Contoura works on the line of sight, and your ablation is going to be very, very perfect on your optical system and the center of the pupil, which is what we do in most of the wavefront optimize. Is your center of the pupil is the line of sight. So I think in that way, Contoura does work very well according to me. These kind of cases were done, and it works very well.
That was the logic that, ideally Contoura should be doing well, because you're actually treating on the visual axis, not on the center of the pupil. But, I was going across this one study which we pulled out where the enhancement rate on Contoura treatments with hyperopia was very high. So that's what kind of, worries you, whether, just thought that you can probably, those who are using
enhancements have to be told to the patient of hyperopia.
Hyperopia, anyways, you're going to tell them. But
treatment we do.
Absolutely, hyperopia, you anyways prepare them for enhancements. But if the enhancement rates are like more than 50%, that could kind of, yeah.
So. We are not.
I don't think so.
We have hardly enhanced anybody.
Yes. I agree.
So would you do anything differently on the planning? Like, can you kind of show anything on the plan, or should we just go ahead to the next?
I think straightforward. What I would do differently is I'll go for the full go a little higher than what he accepts.
Sure.
Potentially dilated hyperopia would have an issue on him.
A question, was this study from John back on those days was, I think, on the pentagram. It was very early days, if I'm not
There was
mistaken.
one study which I was just researching this, and we came across one study which showed about 28 eyes or something, and they showed almost 10 eyes requiring an enhancement. That's what I read.
This was back from 2006 or 2007, and he was his first attempt with Contoura, not Contoura vision, was basically oculizer guided with this with the oculizer, not with the topolizer. If I remember
the
well.
study I came across was a Contoura, but let me just kind of look it up. Okay.
Yeah.
So anyway, I think Abdul, you can stop sharing this. So I think this was just to take the opinion of everybody. I think we can go on to the next one because we are running really behind schedule. So
Gaurav, you need to introduce Sisimos.
Okay. So yeah. So I think Sisimos has been with Wavelight, long before Alcon came in. And we were lucky to have Sisimos in our Wavelight user meetings year after year, and had a great time developing Wavelight with almost 15 years. Many of us have been there since then. Rohit was there, Dr. Wavikar, Dr. Dami, and many of us, Dr. Sarvate. So Sisimos is Director Clinical Applications with Alcon and Wavelight. We're part of Alcon, and he looks after. He's been a great help all through these years, helping us innovate and bring newer things. So Sisimos, I think you're going to talk about some basic, very important concepts. You've given us a lot of concepts through this webinar anyway, but please go ahead and share your thoughts on how we can use Contoura better. And I'll be grateful if we can just, we are running really behind schedule. So I'll be grateful if you can keep it to time.
Okay, can you see the screen already?
Yes.
Yes, we can. Yeah, thanks.
Okay. Good. So I want to really go quickly through this. This is a little bit of history also here. So we did in the lab look at the topographies, and we created the kind of calibration and globes. And what we did find is we created astigmatism with either no eccentricity, which means with spherical, and we did create it also a calibration globe with two different eccentricities. And as you can see, astigmatism is not consistent. If you look to the lower bottom part here, the difference between the steep and the flat meridian is changing throughout the optical zone. This would mean that a patient here with different optical zone would most probably reduce his spheric astigmatism with optical zone. So this was the first thing that we did find out. And the second thing is we looked a little bit careful also to the K readings and how the K readings are calculated and how the astigmatism is derived. So this patient is a true patient. So if you look at the K1 is 44.5, K2 is 44.6. You can see this here. And the astigmatism accordingly is 1.5 diopters. This is basically just taking the two half meridians, combining them together, take the average, and then you have the astigmatism. This is, and especially if you have a keratoconus case, this is not true. So don't always rely on this 1.5 diopters. This is very true for the central area and for astigmatism cases that is by the book, perfect one. If you have astigmatism that is Coma inflected, this number is not reliable at all. I use since years now, for the first fast screening of astigmatism, I don't even look back into the original screen here. I will go immediately to the Fourier, because Fourier shows me the original topography. And here one could say, oh, this is astigmatism. But if you look closely, you have basically astigmatism primary order with astigmatism secondary order combined with Coma. So here, this is Coma, and this is primary astigmatism and secondary astigmatism. And the software tells you basically two figures, and I put it here. This would be the K1, K2, as we see in the overview. This would be now the astigmatism for the central area, 3 degrees, and for the peripheral, 154 degrees. So you have two different astigmatism powers, although you have one topography. I encourage you maybe to look from time to time to the Fourier if you want to find the true nature. And this number here is pretty quick visible. And you can see now that in this case we have, depending on where we're looking at, 3 degrees and 154 degrees. Now, to the point, if anterior and posterior do play a role, yes, it does play a role. I did on against the rule astigmatism, the calculations front and the back, not looking at the power suggested by the pentagram here, but rather by taking the steep and the flat and adding them to each other. And as you can see, also for against rule astigmatism, the power is reduced. So be careful if you look at the against rule astigmatism. Sometimes in the literature you will find it's increasing the power, but this is not true. This is not true if it's a real astigmatism against the rule. Sometimes you have a very regular and posterior surface, but the anterior surface is irregular. So this all help us. Forget about this. This is only with a vector, so I will go quickly through, so it's not even a change. Now, we discussed this a lot. Why they don't match? Because we discussed today that we have the astigmatism in the front, we have high orders that contribute to the topography, we have the posterior, and then we have the rest of the eye. So the reason that they do not coexist, I call this part one, it's internal optics, like posterior corneal lens or accommodation and retina or lenticular astigmatism. And the second part is Zernike polynomials and calculation or high order aberrations. They practically come together, but we need to separate them and to look at them where they come from. So this is a simple case on how to detect lenticular astigmatism. We've been here looking at the posterior surface of the cornea is 0.1 diopter. The high order aberrations are from the center, this red area here to the pink area, 2 microns, and the patient has a difference between the Contoura vision at 6.5 and the manifest of almost 1 diopter. This does not explain this difference. And therefore, here the better choice would be either to do custom hue or to do topography guided, but then use really the manifest. So it is a very simple way of looking at, you just look at the high order aberrations. Here it's only 2 microns, the posterior is not contributing anything. And therefore there's no logical reason why to believe the difference is coming from the high order aberrations. It must be now lenticular, there's no other choice. The posterior is also not contributing. Now, I would like also to point something that we did find out already in 2003 when we looked at the wavefront. Here we have spherical aberration, and this is the C4, C12 calculation that we also do. And this patient has at 7 millimeter, 1.97 diopters. And if you go to the 4 millimeter, 2.7 diopters. So this is a difference of 0.75 of diopters just by going from 7 millimeter optical zone down to 4 millimeter. In practical purpose, this patient at night is +1, +2, but during day, he's +2.75. So the same thing can happen to you also with Contoura vision. This patient, this is the same patient, the same eye, 7 millimeter. His refraction is here 0.23 diopters at 176. At 5 millimeter, unfortunately, wavelet cannot offer you at the moment the 4 millimeter value, but what you can do is to reduce this to 5 millimeter and see what happens. And here you see it's 3/4 diopters at 5 degrees. So this is a difference of a half a diopter at 9 degrees. Now, why does this happen? Well, if you look at the polynomials that have been created by Zernike, yes, we have the problem that, for example, to project spherical aberration, you need to use a little bit sphere. So this is a paper that has been published by Gatinel, Dr. Gatinel, and here you see the pure spherical aberration, and it's the compensation with Zernike polynomials. Let's make it simple. If you want to show with Zernike spherical aberration, you need to take a little bit sphere out to put inside there the spherical aberration in simple words. So therefore, the calculation of the spherical of the sphere and the cylinder in a very complex corner is not working. And I'll show you here a clinical example. So the Zernike calculation of a post LASIK case with a small optical zone goes -1, -0.5 at 171. The patient is accepting 1/4 and 1/4 at 157. The Gatinel mathematics would give him a half-a diopter minus a half-a diopter, 152, much closer. Now, this is something that we need to understand. If you look to the Contoura vision, if you need tomorrow to innervise, if you look to wavefront guided, the refraction that you see there is a calculation from all the Zernike back into sphere only. But keep in mind, as more spherical aberration you have, as more pupil size depending, your refraction will become and biased by higher order aberrations. So therefore, especially for highly aberrated eyes, be very careful, comparing manifest with the measured. This is something that sometimes will not come close. And especially if you look at the manifest that is measured 3.5, 4 millimeters, but the calculated at Contoura vision away from guided is 6.57. So you need to do two things, bring them together, and as soon as you look at the higher order aberrations, there are a lot, don't trust the Zernike polynomials back calculation so much, but look at only at the higher order aberrations. And this is a way of what Dr. Lobanov is doing with his talus calculation. He tries to overcome the Zernike polynomial issue. Another thing that I would like to show you something is how important is also to please look closely how well your measurements and your data set is. This is a data set of the same patient, where I took 3 exams, and the resulting refraction here is 1.72 and 19 degrees. If I took the measurement 1, 4, 5, and 6, I had 4.42 at 19 degrees. So the first thing that I ask the customer is, please, before you go ahead and treat the patient, by the way, the average of all was 3 diopters, ask them, please do me a favor and do the exams again. And I got yesterday the new exams, and now all of a sudden you see the astigmatism is minus 0.62 at 22 degrees. So you see how important it is that you have really good data when you go ahead and treat patients. So you can't be, as we learned today, it is not making a big difference, but in cases where you have completely conflicting data, it makes a difference. So This is basically in a fast running manner. The latest findings that we have been working through. So for you, the take-home message is refraction is Lysonicate polynomials pupil dependent. Second, be careful as higher aberrated your cornea is, as less reliable is your display. And third one, don't trust the K readings simulated refraction. And the very last one, please be very careful that your measurements are consistent. Thank you very much.
Thanks, Isimos. Those were wonderful tips, and I think very good example towards the end. And thanks a lot for sharing all those tips with us. Dr. Wavikar, let's move on. Because we have, I'm sure we put everybody to. Yeah, let's go ahead. Yeah.
Precisely. So we have come to a session where we are ending the Alcon recommendation talk. Of course, there is going to be overlap, but we are now trying to understand what are the other things. So in that, whether topoguider can be applied for cases like keratoconus, C3R, and then Dr. Rohit Shetty is going to talk about his 3C software. He has got some novel points, and we all know the way he thinks. He's a visionary. And after that, of course, Dr. Mark Webinar, we have been talking so much about porcines. So we'll start with the first case, Shreyas Ramamurthy. Dr. Shreyas, can you start with topoguided for keratoconus?
Where the subjective and topographic do not align well at all, and we'll just quickly see how we plan the two cases. So,
Abdul,
if you can share the
just a quick one for the first case. The pupils looks completely irregular. It's oval. There's something happening there at the pentacam at least.
Let me just.
Abdul,
we can look at it later on.
Okay, we can look at it. Yeah, sure.
Yeah.
So
fine.
Going into so this is something, which can happen with keratoconus cases quite often. Even though it's not a very advanced keratoconus, you can have a Q value which is beyond -1, and obviously the software doesn't allow you to do that. Now there is still a certain amount of debate on how much your target Q value should be. I mean, we are going to be doing an additional myopic ablation on top of this. The Q value is likely to reduce further. There is some data suggesting by, a paper by Dr. Rohit Shetty's group also about Q switching and bringing it down by about 0.2 in a higher degrees of Q value. However, we don't have enough data yet to know exactly what would be the ideal Q value. But yes, I do bring it down when it is higher. In this case, at least, I would have gone ahead with something like a -0.8 or a -0.75, which would be a minimum which I would start with. If you can, Abdul, you can just put a -0.8. Optical zone, rarely are we ever going to do 6.5 in a keratoconic patient. Definitely, it's either a 5.5. Maybe in early keratoconus, I would do a 6 mm optic zone. If you can go to the next slide. Yeah, you can reduce it. Yeah. And getting repeatable scans is a significantly greater challenge in keratoconus than it is in the regular corneas. The central 3 millimeters, where we look at a 0.75 diopter difference for our regular Contoura cases, is definitely a higher challenge in keratoconus. But having said that, these are patients where we are trying to improve the final visual outcome. We are not really looking at the final refractive accuracy, neither are we trying to achieve Hyperopia. So this is kind of getting us the best of both worlds. Let's just go on to the next slide, please. You just enter in the refractive data, the central corneal thickness, and next slide. Yeah. So again, as you can see here, we can reduce the optic zone size and yeah, maybe 5.5 and make it a 0 power map. So one important thing before we even plan our 0 power correction is to see if your topography guided profile is going to match your the pentacam picture, the topography picture that you get. Now, if you remember the first patient, very central cone, fairly symmetric. It almost looks like it's just a case of very high astigmatism. But obviously there is a posterior float elevation and scissoring, which makes it keratoconus, but it's very symmetric. The next example, which we'll see, is not so symmetric, and obviously the zero powered ablation will be much higher. Here you can see, because the cornea is fairly symmetric, the central ablation for a zero power is only 7.5. And of course, you have a peripheral ablation to neutralize some amount of flattening which you had superiorly in the topography. Now, having, let's say, in this cornea, which had a minimal thickness of about 480, 490, I have sufficient tissue to play with and try and debulk the cylinder to the extent possible. So now the central ablation is only about 7.57. So now I would go ahead and let's try and enter, let's say, about 3 diopters of cylinder. When the axis is different, at least in these cases, I tend to go ahead more with the topographic axis, closer to the topographic axis, and it does work quite well. Because again, our subjective refraction in patients, unless they are really correcting to a crisp 6.6, which is very rarely the case in these keratoconic patients, the subjective cylinder is not very reliable. So if I'm really treating these patients, I hesitate much less in going for the topographic cylinder. And let's say a -3 with a 160, you can see it's still only 39 microns. I can add a little bit more. And very often, even in patients, let's say patient who has a BCV of 612 or 2040 and is accepting only a -2 cylinder on subjective refraction, but would have something as high as a -5.5 or -6 on your topography. So you can easily go ahead well beyond your subjective refraction in these patients as long as you have sufficient tissue left. So in here, we could go even higher, a -4, or and enter it and see. -4 or a 4.25, yeah. So something around 4.5 would be the ideal, where we are reaching around 50 microns of ablation. And I would leave the...
Can I intervene?
Yes, sir.
You did LASIK or you did PRK?
PRK, sir. I never do LASIK for any of these patients.
Yeah, exactly. Those flap thickness.
Flap thickness is 50. Right.
Then we'll have a better idea.
Yeah, absolutely.
About the residual, huh? Yeah, sorry.
Yeah. No problem, sir. No problem. I mean, it's always topoguided PRK. I'm sorry if I didn't mention that. Never topoguided LASIK. So again, there was this earlier discussion which we had with topoguided Contoura, where we had this discussion about the epithelial thickness playing a role. And epithelial thickness is going to play a far greater role in keratoconus. As we all know, the epithelial thickness is going to be quite different. And unless we have a device which is going to be able to measure your topography and guide the treatment at the level of the Bowman's or below the epithelium, whatever scans we take on the topography guided treatment, which is on the tear film or on top of the epithelium, is never going to be extremely accurate. So in all these patients, I try not to remove the epithelium manually. When you remove the epithelium manually, you're actually removing only the epithelium, and you can remove a thinner epithelium in the center and a much thicker epithelium around the base of the cone. So in all these patients, I go ahead with just a PTK mode and do a 40 or a 50 micron ablation based on the ASOCT epithelial thickness map that I have. At least the assumption is, to a certain extent, though it may not be perfect, to a certain extent, when you're removing a uniform amount of tissue throughout the anterior cornea, the topography is more likely to resemble what you've measured in the preoperative period than removing it manually, where you're likely to have a much greater difference from center to periphery, let's say by doing an alcohol epithelectomy. So PTK is my preferred choice in these patients, and there's a couple of papers to also support that laser PTK versus mechanical or alcohol debridement works better. We'll just quickly go on to the second example, and then I think we can discuss. If you can take the next case, Abdul. If you'll remember the topography, it was a much more decentered cone. And in this case, the degree of difference between your subjective and your topographic cylinder is likely to be much higher. I think her name was Kritika. Okay, if you can. Yeah. Again, target Q of about 0.7. I don't really change it too much. I would just leave it at that. Yes, you can argue, you can bring it down to 0.5, 0.4, why not? But like I've, at least probably we don't have the right tools to measure if the Q switching is giving us a better outcome. But in the cases which I have done in our experience, between changing the Q value by about 0.225 compared to not changing them, I have not observed a significant difference. But I'm sure the experts can have a different view on that. Let's move on to the planning, please. So mind you, now this is a patient who's also accepting a small hyperopic sphere, which is not uncommon in keratoconic patients, because in a more decentered case, there is a certain portion of the anterior part of the cornea which is significantly flatter, and therefore these patients will actually end up accepting a small plus sphere along with a higher minus cylinder. Please go ahead. So now in this patient, again, let's just zero in. Now, if you can see, if you remember, I wish, and normally in my presentations, I keep the pentacam image right next to this. And if you can see, the zone of hyperopic and myopic ablation is spot on. This is a very, very good case to treat. Like where you can see, if you had compared it with the pentacam picture, the area of myopic ablation is exactly over the peak of the cone, and the area of the hyperopic ablation is peripheral to the flatter area. And this is a perfect scan that you'd want to ensure you have a much smoother contour postoperatively. Again, planned flap will go down to 50. Optic zone would go down to 5.5. And in these patients, again, like I said, now this patient, even with a 5.5, because of the higher extent of irregularity compared to the previous patient, we have almost exhausted 30 microns of tissue with just the zero power itself. So the amount of tissue that you can ablate now is much lesser. So let's say, let's just put a minus 2.5 or minus 3 cylinder and just have a look. So if you put a minus 3, now this is going to 55 microns, and the patient's corneal thickness did not allow, just put 147, Abdul, I think that should be fine. We'll just go with the topographic cylinder for now. It's just to show, and in case you had a 6 millimeter zone, just to give you an example, 6 millimeter zone, and this was 61, 62 microns. Now in these cases, when the patient is accepting a small hyperopic power, even if the patient is not accepting, adding a small degree of hyperopia will help you in actually reducing the amount of maximum ablation, and you can use that, especially when you still have a very high cylinder and you want to debulk it a little bit more. So let's just go ahead and put a +1 there in the modified refraction. And as you can see, the maximum ablation is going to come down from 62 to 54 microns, and the central ablation, which is what we are more concerned about, is coming down from 42 to 34 microns. So adding a little bit of hyperopia to the correction helps. And now that I am down to 54, I could add a half a diopter cylinder or just leave it at this. So this is how I would go about planning these patients of slightly more irregular cornea, and it works extremely well. And these are patients who definitely have a much better outcome post-operatively.
Can I add one or two pearls to it, which I learned from a guy who does a lot of keratoconus? First thing, I would increase the transition zone to the maximum.
Absolutely, absolutely. I completely agree. I think I forgot to mention that 5.5 optic zone, I would definitely increase the transition zone to 1.75. Sorry?
No, I was instructing Abdul to stop share screen. Please go ahead.
Also, use the maximum transition zone. This will smoothen a little bit the ablation, first thing is. Second thing is what I saw at this guy who is really good. He's taking the ablation, including the astigmatism, the astigmatism axis and whatever power, and confirms with the pentacam that the ablation is looking exactly as he would expect. In this case, it would be at 4 o'clock, the maximum ablation, and at 7 o'clock. So it's a kind of confirmation. Why? You have a placebo-based system, which is very good in the peripheral data, and you have a pentacam, which is very good in the central data. If it coincides, you can be a little bit more confident that it's going to give you good ablation. The third pearl that I would like to do is the guy which I'm talking about, and he's really good and well experienced, and he sits usually in Switzerland. He does first the PRK part on the epithelium and comes on with the PTK. Why? His assumption is following. If you do a keratoconus case, the most treatment will be over the cone and at the periphery. This is going to hit the tissue up. While loading the PTK, the tissue that has been damaged is the epithelium. And now you go with a PTK smoothly in and you have less scarring. This is the theory. So I wanted just to share this, pearls from...
Very good.
Yeah,
very
I
good.
think the Schwinn platform does that even for regular PRK cases, where they do the PRK first and then the PTK, even for regular cases. And,
I'm not so happy with regular cases, because in the regular case, usually the heating is quite well distributed because it's a spherical or hyperopic or astigmatism. The disadvantage there is if you do first, you don't see if you go through the epithelium. And especially if you have a fixed epithelium depth, you don't know, did I go through or do I will receive a smaller optical zone? So therefore, we willingly decide on Streamline not to do that. But in keratoconus cases where you want to have the least amount of damage, heating damage, because imagine this is like a hyperopic treatment of 4 diopters, 5 diopters, which will give you for sure hazing reaction and so on and so forth. There, it smoothens things a little bit down. Yeah, I agree, Srin does it by purpose. I have the feeling, yeah, well, for regular cases, it's not so good.
May not make a difference.
Yeah.
Dr. Rohit Shetty, your comment about this topo guided in keratoconus?
I think Shreyas explained exactly what we've been doing. And one of the things is the last maybe 4 or 5 years, I used the Schwind also. Between Schwind and this, I more or less converted myself completely to some form of the refractive correction or the other. And we've been analyzing with Shreyas about our data, about people have been saying about whether it's progress, and we've been very fortunate. And this is what many people have been telling me, that when you do a topo-guided treatment, even if a small treatment, they don't progress. I have data from 2008, 2007, 2008. And the progression is exactly the similar or hardly anything compared to a normal cross-linking. So some amount of scarring, some amount of wound healing or wound modulation actually may be helping. So this is my take on this.
Wow, that's a new point.
Dr. Rohit and Dr. Shreyas and Dr. Rohit, the second case that you showed where the cone was off center, would you still stick to 5.5?
When we say, I mean, it's off center, it's not a very grossly decentered cone. Having said, and we are, yes, sir.
Yeah.
It's not a grossly decentered cone, and what looks much more decentered on the sagittal curvature on the posterior float will not be so decentered. A very decentered cone on the posterior float, generally the BCVA is poorer, and these patients don't necessarily do extremely well with topo-guided treatments. And I don't do it if the BCVA is below 612 or 615. I found that the improvement the patients get is not good enough for the procedure to justify it. So centered or slightly decentered cones, yes, it works quite well. And also, I think in the more grossly decentered cones, the thickness is also low enough that you're not able to do a topo-guided.
Just 2 quick comments. One, you have to take into account the flattening effect from the cross-linking itself.
Yes.
And this is why adding a little hyperopia is often very helpful in these patients. For me, I usually add about 0.75 depending on average. The second thing is, Shreyas, I may change your mind. I'm going to calculate with Forsities in a decentered cone. And the thing is, when you have a decentered cone, that cone is essentially a massive talus mountain. And it has a huge, as you move the cone to the periphery, it has a huge effect on the amount of cylinder. And if you take that into account, I've gotten better results with my decentered cones than I did at first. So I might change your mind on that.
I'd be very happy to use the try out the 4 series for keratoconus patients. I haven't done it yet. I mean, in our earlier discussion, maybe a few months ago, you had said that you were developing it and you would share your results on how it works. And I think we'd be happy to try it out with the 4 series for keratoconus patients.
Fine, great. Let's go ahead with the next presentation. Dr. Dhami is here. So we have got one more scenario to be discussed, that he has done topo guided treatment in the post C3R case.
Well, putting it along, it was just satisfying a patient who was a very high slender post CTR, and the only thing he could get was intacts to regularize his refraction. His concern was only that I want to see good with glasses because he had a good vision in the right eye. And what was his refraction was a 12th power cylinder on a topography, and he would accept a manifest refraction of only -2 cylinder with a vision of 6/9. He was explained that whatever the intacts are going to do, we'll try to do it with the surface ablation topo guided. Next, can I see it, Abdul? Next.
Oh. Yeah, one second. Abdul, over to you.
So Shreyas has mentioned a pretty good work, but here is a person who's going to get satisfied. We're mere cleaning up his cornea, rather leveling it up. We put in his refraction. I'll show you. Everything was normal. Taking graphs in him was normal. Taking all record was abnormal. But we did get some good. And as we went down, can you go to the next, please? Next. So you see, we cannot correct any refraction here. Once we zeroed it down, we were ablating about 42 microns and a really regular treatment, what we were thinking on the graph. And we went ahead thinking if nothing is done, we are not going to do anything wrong. We did it. And final results were excellent. The boy came back after a week to tell us that his all shadows, halos are gone and his refraction is pretty good and correct. And he has got the same effect which you could have got it with Intex. My take-home message is at times you can help merely by correcting his spherical abrasions on the cornea, and he will really have a good vision with glasses. Thank you. I would love to have opinion of Shreyas, what he would do, whether Intex or correct the refraction in this boy.
So, nice example. This almost looks like a treatment for enlarging the optic zone. And probably that really improved his photic phenomena to an extent, because there's almost, there's very less ablation in the center. It is true that in some of these very steep nipple cones, very small cones, but very steep corneas in the center, the patients actually have poor BCVA. And definitely shaving off some tissue can really have dramatic effects in the visual outcome. And there are patients who do extremely well. Some of these very steep nipple cones are actually the ones who have the greatest effect. Having said that, in a post crosslink cornea, all bets are off on how predictable the outcome is going to be. And there's always a little bit of challenge, especially if there is a certain amount of haze or scarring which is already pre-existing. Then not only our ablation rate, but also the outcomes are going to be a little different. So, but I'm glad that he had a very good outcome.
The only positive point was the whatever manifest refraction he was accepting, his vision was 6/9 with that. And the moment we regularized the cornea, removed the corneal abrasions, whatever you call it, you know, his things was very well happy with the glass cylinder of minus 2.5. See, he was a rural farmer. And to explain him that I'm going to laser, we have a soiling. You laser the soil, you laser the land for cultivation. He understood it immediately. Yes, that will do, sir. And things worked very well for him.
So I disagree that this is like enlarging optical zone. It looks in the first moment, but be careful what the center does.
I
I
didn't say it is enlarging optic zone. I just said it at first glance it looks like that, but it is helped in shaving off that portion of the cone, central cone, which has helped.
The central area is about 30 microns. And what wonders me is the 7 diopters of astigmatism. And there you see that it's basically a secondary order astigmatism, mainly contributing. And therefore, what you have done is basically you have corrected the central vision. And this is the difference. So it's like you had a steep cone in the center and you removed it. So refraction-wise, this can give you, just as a warning, a super surprise in sphere.
Okay.
Yeah. You've been very lucky that you didn't have a super nice -5 or -7 coming out of it, because I have such cases like this.
That's what he was expecting. He said if we get a super refraction, an ICL into it.
Correct. Very good point, Sisimos. Yeah, I hope you can hear me.
Yeah.
So very good, point brought by Sisimos that the topography does throw refractive surprises. That is the reason why initially it was more of a reparative procedure till Contoura came. Now, to make these calculations very simple, we have two stalwarts going to talk about the software. First is Dr. Rohit Shetty and then Dr. Mark Lobanov. So, Dr. Rohit Shetty, over to you. Please give us a glimpses of 3G. You are muted, Dr. Rohit.
It's going to be, am I audible now?
Yes.
Oh, yes.
So it's going to be a very small presentation. I'm going to skip a lot of slides. I think everything has been discussed more or less, but I added a few slides. I refined my presentation a little bit, which probably is in sync with what we have been discussing the whole evening. And these are my financial disclosures. And we have mentioned about what does a cylinder comprise of astigmatism, or you can have a nice rainbow chart of multiple pizza combinations out there. So when we did our 3Z nomogram, we divided our whole component into this. The group 1, when everything is good, the group 2 is subjective less than the measured, and the group 3 is subjective more than the cylinder. And I think we have discussed very nicely, so we have an idea about this. And this is the background about how we have planned it. So one major factor why we had 3 hours of discussion today is when we talk about Contoura, there are a few things which are completely missing. One is the epithelial profiling. One is how is the lens placed and your abrasion and its whole dynamic compensation. So I'm going to go a little bit into a new component, what we have been working on. This whole project we've been working for the last 8 years, but I made it into a nice study now during the COVID. So basically we are looking at nerves, and at this point of time, if I say that the nerves are very important for your Contoura, if I ask this to Sisimos, he says, well, yeah, maybe. but how does nerves really have an impact? So next few slides is all about that. It's very difficult to summarize this in a few minutes, but what I feel is a healthy nerves brings healthy epithelium. They're all hemostatically they are linked, and you get a good vision. These are unhealthy. These are the healthy nerves. These are the unhealthy nerves. You can see all the inflammatory dendrites, microneuromas, all poor components out here. And what happens is these are the ones which brings you unhealthy epithelium. So entire today's discussion all was on Betacam or oculizers. But now I think to understand Contoura or to work on Contoura better, we have to move out of just a tomography-based examinations. And we discuss about the whole aberrations. Aberrations are just not corneal, even epithelium. So from the last 8-9 months, close to a year now, we started using more of MS39 in my practice. And we started looking at the components of epithelial cylinders. This is very important because this is normal. And see the epithelial cylinders. This is from the epithelium. And this is keratoconus. The epithelial itself is giving you 2 diopters of cylinder, 2.8 diopters of cylinder. This is from the epithelial zernicate. Of course, optically, me and Sissimos can argue about how relevant this is, how strong this is, but that's a different discussion. But epithelium can cause cylindrical change. Now, how does it measure? Okay, MS39 measures your epithelium. It looks at your anterior stroma. And this is what Shreyas mentioned. This is at your Bowman's level. So it gives you elevation at different levels. So you can virtually at one go. At this point of time, you don't have a curvature. That's what we can create. That's what the software we built. But this is only the elevation map. It's still okay. Now let's look at this. This is a patient just yesterday, and you can see that there is some amount of elevation changes. If this patient had, but your whole your biomechanics is normal, that's fine. But look at this. This is on M39. This is the amount of thickening, which corresponds to amount of a mild 1.5 diopters of elevation. And this is your anterior elevation, not very significant, but stroma does absolutely nothing. But what is very interesting is just look at this map here. You have around 0.4 diopters of cylinders coming from epithelium. This is interesting because your topographies is a mix of your cornea, and your anterior cornea is a mix of your anterior, posterior, and epithelium. But many times we don't see the epithelium. Exactly the same thing. You can see that this is a change. And when you actually do an aberration maps, you're actually picking up these also. And this is not going to be same. You do a surgery, this will change. The epithelium is dynamic and it keeps changing because a new epithelium, you put steroids on it, it will change. You put a trehalose drops, it will change. So understanding epithelium is very, very, very important with these. I have hundreds of these kind of cases. Now we are building an AI model which will be completely based out of just all your bad Ds and everything, because that is giving you, for example, here the bad D is suspicious because there is some amount of elevation here, and that is actually matching to your epithelial change. So it just means that how little we are looking at the epithelium as a major factor for understanding. So we use we're not use the epithelium yet. We use whatever we discussed today into this component, and we looked at, to make it simple, we looked at the changes here. We looked at how much is it compensating, how much myopia it is compensating, how much I had to correct the cylinder. This is like the whole software has its own self-learning mechanisms to build it, and then it's very simple. The reason many times I've used this, we did analysis of around 500 eyes, and we did not find in a healthy patient a huge impact of posterior cornea on your cylindrical component. So at this point of time, we have not added that, and this is all from your zero rule, and this is how it works. We have given it already. This is a very important slide. This is one of my last few slides about astigmatic. What happens to your lens? This is from Osiris. it tells you in a healthy patient, the astigmat, the accommodation is perfect. So you can this color, blues and greens means you're accommodating healthily. And in this patient, you can see how the accommodation is. This side is accommodating more and this side is less. This is a very beautiful picture. That means your accommodation is actually, it's like a cylinder. That means that is why your patient has more acceptance. You're measured and you're actually, it's trying to compensate something on your cornea. And if you see this, it's actually a very nice picture. I think this is not playing, I guess. This is last video. And you could have seen that this whole area was extremely red. When you see red means that this patient is actually having a pseudo accommodation, and that's why you can see that his cylinders are very high. And this is our knowledge we have built into our thing, and these cases have been all discussed, so I don't want to go into this. These are all the similar cases. The one thing I want to say is the group 3, where your cylinders are high, is always because of some issue with your accommodation or a fusion or a convergence or a divergence, and you have to do it. Even if you do a perfect 20 by 20, the patient will come back to you in 2 or 3 months complaining that he can't fuse or he has headaches. And this is something we have submitted to IJO now. The manuscript is under review. It's about, you can just give it to your optometrist and they can probably give you the entire range of what we do when you have a person who has excessive accommodation. How do they go around with this? Basically trying to look for phobias or accommodative issues. So results have been good. This is something which we have written it up as a publication, and I mean, this is what I mentioned. All the groups had very, very strong near 0.25 odd postcorneal astigmatism. And most important thing, what we found in our data was the depth of focus, which we studied using the eye trace, and was the best. And this is got accepted in JCRS, where the LASIK had the best depth of focus compared to SMILE, and for some reason it was PRK, maybe because of the epithelial remodeling, we don't know. PRK had the least depth of focus compared to all the 3, especially this was on the Contoura. And what we have done is, this is my last slide. We kept it as simple as possible and single step, and lot of thought process, whatever we discussed was added into it. And what we found was, more than the quality of vision, we found the depth of focus, which is very much necessary for today's generation and all the young people, because it's not in 20 by 20 or N6, it's about your depth of focus. And the most important thing I want to bring in this presentation, the short presentation, is there's a huge impact of epithelium and epithelial remodeling and healing in the way Contoura is understood. And the first 2 cases I just showed explains that if there is epithelial cylinders also contribute a lot to your confusion of Contoura. And if you do not see your epithelial map and then plan your Contoura, you may end up in surprise. So epithelial map is as important as having a pentacam map. Because if you have an irregular epithelium, one of the issues with the OptoView, I mean, the new Avanti has a 9mm zone, but we have to look at a 9mm epithelial maps, because that's where you actually see the changes. So this is something which is the take-home point for me. Epithelial map, if you have, it's probably one of the most useful tools here. Thank you.
Thank you, Dr. Rohit. Dr. Rohit Shetty had conducted a seminar on MS39 about 2 months back, which lasted for more than 3 hours. And those who attended would have understood what he was trying to condense in 5 to 10 minutes, what he had spoken that time. It's very difficult to condense such a big presentation. And he had also shown us the video of that lens accommodating last year in Bangalore over a refractive surgery conference. It's a really nice presentation. Thank you. We'll go to the next speaker now, and then we'll discuss both the softwares together. Can I have Dr. Mark Lobanov with his presentation on 4 cities?
Yes, I'm going to share my screen now. So rather than go into the theory behind Forcides. I was going to just show you how it's used to plan a few cases. I'll pull it up. It is linked to the cloud. So we log in and we pull up our calculator. I'm going to open the first patient's image. And I'm going to go through this at the speed that I normally do to calculate cases, and then I'll go back more slowly. But what I want to show is that planning for Contoura does not have to take a lot of time, and it can be very easy. That's our answer. This sphere has already taken into account, we talked about maintaining the spherical equivalency, so it's taken into account when we've changed the cylinder from what was at the manifest. It's adapted for that. A nomogram has been applied to this, so it's already nomogram adjusted, and we have balanced out the C4, C12 based on the amount of tissue ablation in this mid-periphery. So it's done everything for you. It's come up with the cylinder and the axis. So let's go back through that a little more slowly. When you pull in the image from Alcon, it identifies the patient's ID number, date of birth, name, knows that you're dealing with the left eye here. You can target different refractions. What you need to do though is you need to confirm that the data has been transferred accurately. So this gold box tells you what should be right here. And as you hit the tab button, it jumps across so that you can identify this. This data here, topographer anterior corneal negative cylinder and posterior corneal cylinder, I agree with Dr. Shetty, absolutely. The majority of cases, the posterior corneal's contribution is somewhat low. Occasionally, it will be at a different axis than what you expect or a different magnitude. So we do try to consider that. But this data is pulled in automatically from a Pentacam or G4, so you don't have to type it in. This is the maximum tissue ablation at the peak of what I call the talus. It's identified here, 10.3 microns, and this is the center ablation here. So the software has identified the taluses. It's given them a vector contribution, and it has come up with our calculation here. So that's kind of an easy, average, run-of-the-mill case. I'm going to run through a little bit more difficult case here. Pull up the correct one, left eye for this patient. So I'm going to confirm my data. But notice here something. Patient in the clinic is asking for no cylinder correction at the phoropter, but we're identifying one diopter of astigmatism here in this cornea. And now we can kind of see why. This patient, a 12 micron elevation, we have two taluses here. With this tool, I want to make sure that the software is identifying the center of the talus. We want to identify its geometrical center. So by sliding this tool, we've moved the analysis just slightly, and we hit calculate treatment. So these vectors here, one vector in green is for the total corneal astigmatism, the anterior corneal and posterior together. This vector here in purple is what I call the talus or topographic vector. And see how in this particular case, since they're aligned, it has a fairly significant effect, about 0.7 diopters. And then mathematically, we've determined there's some internal lenticular astigmatism. So you'll notice that the corneal astigmatism is roughly exactly 90 degrees away from the talus astigmatism. And so visually, you understand why, very quickly here, why this patient was not asking for any astigmatic correction with their manifest. That this talus has completely negated the effect of the anterior corneal astigmatism. So the vectors give you a quick way to analyze logically what's going on within that eye. Let's move to another image here. Now, what I used for my standard size talus, you guys can generate the standard. Any wavelight user in the world can do this. If you were to plug in a 0 sphere, a plus cylinder treatment, you'll get tissue ablation that looks just like this, about this size, in this location. So you can use that as your standard. This talus here is fairly long. The software's identified it, but we want to give it its full refractive due. So I'm going to identify part of it here. You can manually circle the second talus. You can address its height, give it a height. I'm going to circle another talus here. And we have all of our vector analysis. Now, you don't always have to do this. So if you want to simply let the software choose the talus on its own, this is what Dr. Stonecipher does, and he states that he gets better results if the software chooses the taluses on its own. I'm hands-on, I like to modify things, so I built some tools in here that you can modify your selection of the taluses. Just be a little mindful as you do that. I know we're long on time here, so I'm going to calculate one last case, a keratoconus case. Let's see here. Trevor, left eye. I'm going to open the case. Okay, we got a warning here. There's an unusually large difference between contours measured and what the pentacam has found. And you see that the magnitude is quite different. Foresities is designed to always protect you. It's warning you that, just saying, hey, these are pretty different. Check to make sure you didn't make an error entering the data in incorrectly, but we did enter it correctly. The reason there's such a huge difference here between the placido disc vario and the Scheimpflug, I'll show you that here in a moment, but this data is correct. So we have our taluses here, and we hit calculate treatment, and notice how much our cylinder has been reduced. Okay, in the clinic, the patient was asking for about 3 diopters of astigmatism, but a lot of that astigmatism that they're trying to compensate for these 2 areas here. Once these are corrected topographically, they're going to require less cylinder correction, and that's what Foresities has calculated here. So it is, I have found it's quite useful. I'm going to be publishing the data soon on our keratoconus patients. I'm just going to bring up a very quick 3 slides and then conclude and open up for any questions. So as I looked at thousands and thousands of different treatments as we built Foresities, one thing became apparent, and that is, if a talus is close to the center of the cornea, it throws off placido disc topographers. So here, placido is saying there's 3.4 diopters of astigmatism. Scheimpflug is saying 1.3. So the software knows, it looks at the radius of the talus, and it knows how to adjust and pick the correct anterior corneal astigmatism. What is interesting is the exact opposite phenomenon happens when there is a talus with a long radius. So the radius here is larger. In these instances, the Scheimpflug device is thrown off, and the Scheimpflug devices will overestimate the amount of anterior corneal astigmatism, and the placido disc tends to be more accurate. So the software does all this for you. This is one reason why we use 2 different corneal devices. Foresities needs to know the correct anterior corneal astigmatism. And sometimes Foresities will recommend a treatment that matches up very well with the manifest refraction. So manifest refraction was minus 0.75 at 177. You can see there's a 0.75 difference between the measured and the cylinder and the manifest. But Foresities in this particular case is choosing a treatment close to what the manifest said. Then there are cases where Foresities might pick something closer to TMR. In this particular case, because of the way all the vectors work out, Foresities' recommendation is quite close to what TMR would have recommended. The 50-50 method. Sometimes Foresities will recommend something that's close to the 50-50 method that Dr. Wexler came up with. And then there's certain cases where the only time you'd get the correct answer is if Foresities is helping you. So if we look here, the manifest has 2.25 diopters of astigmatism. We're measuring much less. The placido disc and the Scheimpflug are in very good agreement. So what's going on here? We have two taluses. They're significant in height, 26 microns high. They're in alignment. They're going to have a very significant effect on the overall astigmatism. So if we had treated manifest, this patient, we would have treated 2.25. If we treated TMR, we would have treated 1.55. If we'd used the 50-50 method, we would have treated 1.9. Forces is recommending much less than that because we're eliminating this talus vector when we treat the topography. And sure enough, when we treated the forces on this patient's eye, he ended up at absolute perfection. 0 manifest refraction, astigmatism, and a 20/15 uncorrected vision. So that's where I'm just going to end. I know we've gone long, but I'm happy to answer any questions that may be out there.
Yeah, thank you, Dr. Mark. It's excellent presentation. I would like to start the discussion with 2 questions. Number 1, how many cases out of 100 Forsythia says no Contoura? That is 1. And what is the incidence of refractive surprise with using Forsythia?
So the first question is, what I did is that when I went through thousands of cases, I found there was one small subset of patients that did not do well with Contoura, whether we plan it with Forsythia or any of the other methods. And what's unique about these patients is they have oblique astigmatism on their manifest, but normal with the rule or against the rule astigmatism on their cornea. Forsythia will identify this subgroup. It will alert you if that's happening, and it will recommend that you convert over to wavefront optimized. The second thing, for refractive surprises, I now treat 95% of my patients with Forsythia's Contoura. Our enhancement rate, I looked at my data, combined it with Dr. Stonecipher's. We looked at 4,000 eyes. We had 1 enhancement out of 4,000 eyes.
Wow.
And that should tell you, and that's a dramatic reduction over where I was before. That tells me that these refractive surprises are virtually nil.
Excellent. Dr. Shwes, you have been using Forsythia. Your thoughts?
I mean, I'm been very excited to use the Forsythia ever since Dr. Lobanov introduced it to us. And like I said, it's really made a big difference in the way we understand what we are treating in our patients, rather than directly going ahead with topo-guided treatments where you're, plainly doing a TMR or a modified TMR, where we're not really sure what you're landing on one spot or the other. And Forsythia really helps and breaks it down for you. My only one question, Dr. Lobanov, with the keratoconus patients, which is really the area where I've not tried Forsythia in, the subjective vector component of the Forsythia this thing is not likely to be as accurate, because the subjective refractions, like in normal corneas, which is going to be fairly accurate, is definitely not going to be accurate with keratoconus patients. And you were even talking about decentered cones and all those patients where we definitely struggle to get a good vector, especially the axis is so variable if different optometrists do it even on a single day. So how do you compute what you're going to do for the Forsythia for keratoconus?
That was an excellent question. And I'm going to go back to a comment that you made earlier, or someone made earlier, and that is that the mild keratoconus patients, if they have a good, best corrected visual acuity, you can give more weight to that manifest refraction. But for patients who have advanced cones, like you said, you sometimes get these wildly different refractions, in which case I'm not going to try to correct all that at once. I'm going to do just a purely topographic guided treatment without treating the, let's say, the sphere or cylinder. I'm going to try to normalize that cornea. I'm going to cross-link, and then I let them heal. And in these really bad cones, I often see a little more variability from the cross-linking effect. Some might get almost none. Some might get a dramatic effect if they have a nipple cone very thin. So what I'd rather do is try to make the topography better. Like Dr. Dami said in that one patient, the rural farmer, if you normalize some of the topography, suddenly their manifest gets much, much better. So I might, a year later, I've cross-linked, I might go back and do a second topography guided treatment once I have a more stable and accurate manifest refraction. Another thing I'll sometimes do is I will sometimes, if I've got a really irregular cone, you can't even capture a vario. So what I'll do is I'll do a transepithelial spherical ablation with a 7.0 optical zone just to try to go through the epi, and I'll hit the stroma of the cone first. I'm trying to reduce that cone a little bit. I'll cross-link, and then a year later, I'll see if we can capture better vario, better manifest, and maybe get a better long-term result.
Very good. Dr. Anita, you have been using 3Z. Your thoughts?
It's very nice, very easy to use, and definitely corroborates whatever calculation you have done or you may want to do, and very, very user-friendly with excellent results.
Excellent. So now, friends, I think we should wind up. Dr. Gaurav, we have been talking for 4 hours.
I know. I mean, it's truly a round table, and I wanted to chip in. I also tried my hand on the 3Z as well, and I really found it very easy to use, and we've had good results with that as well. We are still analyzing some of our results, and I'm waiting to lay my hands. We've already got the 4 CDs from Mark, and we are going to try and work with that as well. So I think it's been a great webinar today. I mean, everybody's given out their best, and I think the discussions coming forward have been amazing, and I'm sure they'll be really useful to all the Contoura users in India and maybe even abroad. And I hope we can get this recording right and maybe preserve it for those people who would want to consult on it. So many good points came out from this, and frankly, Abdul was a great help with his live station there, and Sisimos could chip in with his stuff, and Mark with his, and Rohit with his. So I think, and Shreyas, our youngest guy who came in with so many nice cases as well, Dr. Sandeep and Dr. Sarvate with all their experience, Dr. Dhami with his tips, and Dr. Neeta as well with all her wisdom. So I think we've had an amazing session, but I'll leave, to give the closing remarks. I'll request maybe Dr. Dhami to, say he's one of our oldest Wavelight users, and he can, close this out.
Gaurav, it's been wonderful sitting, 4+ hours and just muted and looking at the screen, hearing Dr. Mark, Sissimas, thank you very much for those great ideas. I wish I had got a good market correction in that boy. He always wants an ICL in that. And Wavikar, you did a wonderful job. What a nicely incorporated workshop, webinar, and a teaching lesson. Wonderful. Thank you very much. Thank you, Dr. Neeta. Shreyas, you brought really off the track, beyond Alcon cases. We like them. And everyone, Sandeep, your case was wonderful. Dr. Mark, we're going to work with your ORCD software. We had a wonderful with Dr. Shetty's 3Z. And Dr. Shetty, you always give us a new idea, new concept, and let us take it home that we also use it always. Abdul, not to miss you. You did a wonderful job. Thank you, everyone.
And
wonderful.
Even Entod, I think Entod has been really good with support.
Oh, yes.
Because Dr. Wavikar has planned this out so well, and then Entod has kind of chipped in. And Dr. Wavikar, did you forget one last case from Dr. Neeta? I'm not sure.
No, actually, actually, it is very well covered before.
Right.
And now, I think now people at home will start shouting at us.
I know.
We better stop now.
Before some slippers and shoes start flying on our heads from somewhere. Let's all thank each other, and thank you so much everybody for joining in. We've had a fantastic session.
Thank you, Abdul. Thank you, Abdul.
Till we meet again.
Thank you.
Thank you so much. Thanks,
Abdul. Thank you, Mark. Thank you, Sissimas. Thank you, Dr. Gaurav. Thank you, Dr. Rohit. Thank you, and all the speakers. Thank you very much for contributing.
Thank you.
Thank you so
Good
much.
night. Good night. Bye-bye.
Thank you, everyone. Good night.